Assalamu alaikum everyone. I'm Ibraheem Masoud, third year medical student, and today, inshallah, I'll be covering the second half of the neuroanatomy review questions. And the first half, which is lecture 1 to lecture, I believe, the spinal cord ones, will be covered by my colleague Leena. I'll be covering the brainstem, cerebrum, and the blood supply of the brain, inshallah. So before we start, how are you guys? For those few people that are watching now, how is neuro so far? I'm expecting interactions, guys, because this is literally I'm asking you questions and then you have to answer. So let's start interacting. No interactions? All right, we can keep going then. I just hope it's going well with you. Okay. So before I begin, I got questions from various resources. I got like from USMLE, from Ambus, and then from like simple books like Neuroanatomy, pretest, and this stuff. And I got some from previous batches. And I'll be helping you to know how to exactly solve the question. I'm not here to teach you the knowledge, though if you have a question about any of the lectures that I told you I'm covering, feel free to ask. I'll try my best to help you, inshallah. But my main objective is to help you how to utilize what you know into the question and then be able to ace the exam, inshallah. So you have a patient, he comes in with a dry eye. The right eye is dry. Which nucleus is affected? This is like straightforward. If you know which nucleus is responsible for the gland in the eye, right? You will know which one is the answer, right? So let me see the chat. I think oh, the chat is there. Okay. I didn't see the chat. You were texting there. Okay, so they said B, B. That's right. Why B? Because it's a facial nerve, right? And it supplies it through the superior salvatic nucleus. Facial lacrimal. That's right. It's the facial lacrimal. Absolutely correct, my friend. MashaAllah. Correct. Okay. This was a previous question, by the way. So know each nucleus, know each nerve, know what is the manifestation of this nucleus if it's affected. Superior salivary nucleus is very high yield. Inferior salivary, guys, you know which it's for the glands, right? Parotid and this stuff. It's like glossopharyngeal, I believe. So you have a patient who got a stroke to the posterior part of the parietal lobe. Know the lobes very well, guys. The lobes know them very well. And the presentation of strokes there. What do you think you will have? Just say any symptom. There are two symptoms that were in the exam. You say one of them. Okay, parietal lobe, guys. Remember the broadband areas. Remember, can he speak? Wernicke's? Ah, Wernicke's. But what will be the symptom be? And Wernicke's is more to the temporal, no? Is it temporal or parietal, the Wernicke's? Sensory loss, posterior part. Not able to comprehend. So you're not far off, right? It's Wernicke's, so he will get like agraphia, alexia. He will not be able to read or comprehend, right? So because it says posterior part of the parietal lobe. Now this question looks like it's missing something. It is. You know why? Because it's an alpha question. It's a previous question. So now you'll see the other questions like from books and USMLE, you will find that they give you every single detail. Okay. What is this? The basal artery is occluded. What would the patient have? If the basal artery is occluded, what do you think the presentation will be? Quadriplegia. Why quadriplegia, guys? I want to know why. You should be, but why is this? Can it be anything else? Okay, and you know what? If the basal artery is occluded, what do we call this? Let's say the basal artery is occluded. What do we call this? And why quadriplegia? I want you to think. Is it like the problem in the midbrain? Is it the medulla? Is it the pons? Medial, lateral? Where is the basilar artery? What is it? Locked syndrome. Locked-in syndrome, that's right. So where is this? Locked-in syndrome is which part? Pons. Which part of pons? Lateral or medial? Lateral or medial? Medial, that's right, absolutely correct. So medial pons, this is medial pontine syndrome. Basilar artery, when it's occluded, it causes the Lockton syndrome as well. And this presents as quadriplegia. Why? Because the cortico thalamic tract or the motor the tract responsible for motor functions of the body, it's gone because there is a stroke there, no oxygenation and whatnot. All right. So patient developed right side ptosis and lateral strabismus after a stroke. So the right eye cannot open, and when he looks to the medial side, so for example, when my right eye looks there, it will go laterally. Medial what? You said me what? Not medial. Ah, no, this is the old chat. Never mind. And he had left-sided spastic paralysis. This is hinting to something. So right side ptosis, guys. Right side ptosis, what is it? Oh, sorry. Okay, C, that's absolutely correct. But how do you know it's C? That's right, C. How do you know it's C? Why right midbrain? Now we know it's the right side because contralateral side of the ptosis. Oculomotor, that's right. Oculomotor because he can't look medially, or when he does look medially, his right eye starts to going like this. This is strabismus. It goes laterally because it can't go medially, and you're trying. Right side ptosis because of the nucleus, the Eden file, I think. No, sorry, this is something else. That's a lacrimal. Right side ptosis, that's because the muscle cannot open. What about the left side paralysis? Which tract is this? We just mentioned it. It also goes to the midbrain. Cortico, thalamic, right. Okay. Okay, this is easy. Until now, it's easy. And you guys, mashallah, seem like you studied well. So patient had a stroke after, what does he present with? I mean, what's the problem? He presents, the presentation is written, what's the problem? So he has hemiplegia of the right side of the face. Someone said A. Absolutely correct, my friend. It's A. Why? Because what is who is or which nerve or which nucleus is responsible for the motor function of the face? If you know this, the answer is there. It's a giveaway. It's a free question. That's a facial nerve. That's right. 7 or the facial nerve. This is responsible for motor function, and this is exactly what's happening with the guy. Get a stroke, the facial nucleus is defected, and now he cannot move his right side of the face. All right. By the way, you guys know the upper motor neuron and lower motor neuron of the facial nerve. Know them very well. You will get like different presentations, like half of the face instead of the full. I have a lot of summaries I need to go over with you. Like they're really, really amazing for the brainstem. So let's do a few questions and then I'll show you a trick and see if it worked better with the other questions. So patient had a stroke and he can't speak. Which one is this? Why did you say D? Okay, it's D, but why? What does the nucleus ambiguous do? Who is the nucleus ambiguous? What's so significant about it? Glossopharyngeal. Okay. Vagus. Yes, it's both actually. That's right. 9 and 10. What do they do? What's so significant about 9 and 10? Why can't someone speak when 9 and 10 is problem, like it has a problem? That's because they supply what? Motor for the exactly for the vocal cords, which is stylopharyngeal muscle. That's absolutely correct, mashallah. So this is a high yield case. I'm not sure if you'll get a question, but like generally, just know if someone is treated rapidly with hyponatremia, someone is already answering, mashallah. That's right. If you treat someone with hyponatremia really quickly, so you basically flush his blood with sodium to treat the hyponatremia, and it's a mistake, by the way, it's a mistake. You have to be very careful. He will get what syndrome? Locked-in syndrome. Why? Because there will be a problem with the basilar artery, basically. So basilar part of pons. Correct. Know this. Just know it. When you give too much sodium to someone who have no sodium, you'll get locked-in syndrome, or the basilar part of pons will be affected. Demyelination. Okay. Patient had a stroke. Now, medial strabismus involving the right eye. What does that mean? When he looks laterally, his eye goes to the medial side. This is medial strabismus. Also has left-sided paralysis, right? Left side paralysis, and here medial strabismus. MRI would show stroke in which part? In which part of the brainstem? Is it the midbrain? No. Is it the pons? Is it the medulla? How do you guys know it's the pons? Mashallah, you already know it's the pons, but how? How do you know? It's actually two words. Pons abducens, that's absolutely correct. Because the abducens nerve is in the pons. So you get medial strabismus, and there is also the corticothalamic tract, so you get left-sided paralysis. Correct. Mashallah, I prepared explanation, which is 4 in the middle, and then anything that's divisible by 12, 4 numbers, which is 1, 2, and then 6, 12. Did you guys do all this? Sorry, 3, 4, 6, 12. Did you guys study the rules of 4 and this stuff? Because they really help. If you didn't go through the rule of fours, I suggest you open Boards and Beyond video or any YouTube video. Just go through the rules of fours, guys. It helps you. It's like a life saving. You just memorize one table and you know every single nerve, every single nucleus, where it is in the brainstem. If you don't know it, I can go through it right now, really quickly and really easy, and you will make your life 10 times easier. Wallah, the brainstem will become the easiest subject you will find in the exam because you have one map in your head and you just follow this map. If you want, I can show you like let me see. Do you guys know this as well? I really want to know if you know this. Please go through it. I will go through it. I will go through it. Do you know this, by the way? This table? If it seems complicated, look what I'm gonna do. I'm gonna do something. Let me just hide this control. Okay. I'm gonna do something. Rules of 4 right here. All right. So in the midbrain, or above the pons, there are 4 cranial nerves. What are they? 1, 2, 3, 4. 1, 2 are not in the brainstem. So 3, 4 are in the midbrain. You see, beautiful. 4 cranial nerves are in the pons. What are they? 5, 6, 7, 8. 4 cranial nerves are in the medulla. What are they? 9, 10, 11, 12. 8 is between pons and medulla, by the way. So, like these details, leave them to the end. Now, 4 cranial nerves, you can divide 12 by them. So 12 divided by 3, 6, right? 4, 12. 12 divided by 12, 12 by 6, by 4, by 3. You will get like a whole number without the decimal and the stuff. So these 4 nuclei, what about them? What's so special about them? They're in the middle. So we said 3 is in the midbrain. So it's in the middle of the midbrain. 4 is in the also midbrain, in the middle. 6 is in the middle of the pons. We said 6 is in the pons, and we know it's in the middle. We said 12 is in the middle, and it's also in the medulla, because from 9 to 12 is in the medulla. So now we know these 4 nerves, where are they? Sorry, 4 nuclei, where are they? What about 5? Okay, 7, 8, 9, 11, 10. What about them? They are on the lateral side. So, is in the midbrain any lateral nucleus? No, because we said only 3 and 4 are in the midbrain and they're in the middle. What about the pons? The pons, it has 4, sorry, 5, 6, 7, 8. And we said 4 and 6 and, wait, I'm mixing up. We said 6 in the middle of pons. So 7 and 8 and 5 are in the sides, lateral. So now you know the lateral pontine syndrome, it will affect the cranial nerve number 5, it will affect number 8, and it will affect number 7, facial. This is lateral pontine. Medial pontine, what do you have in the middle of the pons? We said it, 6, right? What about the medulla? Same thing. 9, 10, 11 are on the lateral side, and the middle is the 12, the cranial nerve 12. Now, what about them? These ones in the middle are always motor. The ones that are on the sides are mostly what? And you can see them here, sides, sensory. You have the sympathetic as well, the hypothalamic. You have the spinothalamic. Sorry, Sympathetic is the hypothalamic. Yes, spinothalamic is the for the spinal cord. You have sensory and spinocerebellar. What do you also have in the middle? Starts with an M. Other than the motor, M, medial lemniscus. M, middle. You know what? Let me draw. I don't like speaking. I like drawing. Although I speak a lot sometimes, but like drawing will solve everything. Look at the rules of four now. Can you guys see the screen, the white screen? Can you guys see it? Okay, great. Can you guys draw a line? If you can draw a line, please do it twice for me. If you have a pen and a paper around you or like an iPad or something, please do it. Do it with me. Wait, let me draw a straight line. Okay. Why does it keep doing this? Okay. Can you draw a line? Do it twice. Do it two more times. Right? What did we divide this three segments? Here we have the midbrain. Just gonna write mid, pons, medulla. Right? Don't mind my handwriting. What did we divide the sectors to? Left and right. This is medial. This is lateral. Okay? Medial, lateral. Midbrain, pons, medulla. Right. Now, remember the rules of four. In the midbrain, above pons, we have 1, 2, 3, 4 above pons. 1 and 2 are not even in the brainstem. So 3 and 4 are in the midbrain. Okay. Are 3 and 4 medial or lateral? I want interaction, guys. Come on. Medial or lateral? Remember, the ones that we can divide 12 by are medial. Okay, amazing. So we have 3, 4. Okay. In pons, we have 5, 6, 7, 8. Which ones from these are in the middle and which ones are on lateral? Again, we said 12 divided by 5, no. By 6, yes. Let's put it in the middle. 6 in the middle. 7, no. 8, no. So 5, 7, 8 on the sides. 5, 7, 8. Okay? 6 middle. 8, we can't divide 12 by 8. It's going to be like some decimal number. So we can't like, it's a whole number. Now, we're left with 9, 10, 11, 12. Which one we can divide 12 by? 12. So medial. What about the other three? 9, 10, 11. We throw them on the lateral side. Great. Great. Do you see what I did there? I just distributed all the cranial nerves. Let me write the other side only. It's 5, 7, 8, and here is 9, 10, 11. This is an amazing way to memorize it. Okay. Let's go back to the rules of four. We have 4 motor in the middle, right? And because motor in the middle, like M, we have another M. What is the other M? Medial lemniscus. I'm gonna write a line. Draw a line with the highlighter. This is the medial lemniscus or the posterior column. You guys know it, right? Proprioception and whatever, you know this, vibration, you know this. Okay. Now, I'm gonna change the color here. Okay. Remember, guys, what do you have on lateral sides as well? Side S, spinothalamic. Spinothalamic. Let's write it. Sympathetic. Let's write it. Sympathetic. Sympathetic is for what? Hypothalamic, hormone syndrome, and this. Spinothalamic, pain, temperature, you know? Okay. Let's go back to the picture and see what did we miss. Let's see if we miss anything. Spinocerebellar, I saw it's not with you yet. You're gonna take it post midterm. Sensory, what sensory do we have there? The trigeminal, right? Trigeminal, we already put it on the side. Sensory. Okay. Motor nucleus, we put them in the middle. Motor pathway, we put it in the middle. Like 4 midline columns, notice. Medial lemniscus, we didn't put the MLF. We missed the MLF. MLF is for the correction of your eye movement, but we're not gonna draw it now. Let's keep it as this. Okay. Now, if I tell you, okay, wait, we're not done actually. The arteries, guys, the arteries. Let's put the arteries. Do you guys know where the arteries go? Okay, there is another picture. Let me open it. It's a beautiful, beautiful picture. See this picture? PCA here, ICA, basilar, and then PICA and ASA. You guys know what are those? Okay, let's go back to my drawing. So, the midbrain, PCA, posterior cerebral artery. All of it. All of it by PCA. Just memorize it. Now, the pons, remember, basilar is in the middle. Basilar is in the middle. So the middle is like a base, and this is the basilar artery because it's in the middle, right? So I'm gonna write the basilar here. Now, what about the lateral pons? Who supplies the lateral pons, guys? Do you know what artery supplies the lateral pons? ICA, that's right. ICA, anterior inferior cerebellar artery. ICA. What about middle medulla? Who supplies it? Who supplies it? The basilar artery, when it goes down to the medulla, it changes its name. No, not pica. Pica, medial or lateral? Remember the cerebral arteries are on the lateral side. Cerebellar arteries are on the lateral side. So exactly, pica and pica here, right? ASA is in the middle, right? Anterior spinal artery changes its name. So now you have best map of your life. You see this picture? This is it. This is exactly the picture I'm talking about. This is exactly the same. Exactly. But this have one more track. Or I didn't draw the track, the other one. The cortico-thalamic track. I didn't draw it. Corticospinal, sorry. This one, which is the motor. I said it, but I didn't draw it. Okay. Now here is the game. I'm gonna play a game with you guys. Very nice and fun game. It's good for practice, and you should do it. You should open the paper, know how to draw this by using the rules of four, and then after you use the rules of four to draw this map, what you will do is start thinking, okay, if I have someone, a patient comes in with a stroke in his posterior cerebral artery, what will be his presentation? Give me any symptoms. Or if you don't want to give symptoms, give me what will be affected. I mean, it's right in front of you, but you can, to test yourself, you can just say it without looking at the screen. Midbrain, okay, what in the midbrain? 3 and 4, oculomotor trochlear. That's absolutely correct. So he won't be able to look up and sideways, which is the trochlear, and he won't be able to look medially and move the eye properly, which is the trochlear, right? And he will also have a motor problem if it's medial midbrain. If it's lateral midbrain, he will have ptosis. Why ptosis? Horner syndrome. You agree? What else would he have? Pain and touch. He won't touch it. He won't, sorry, feel pain, touch, and temperature, right? He won't be able to. Okay, I'll make it harder for you. I'll give you a presentation and you tell me what this patient has. A guy walks in. You are a neurologist, and the guy walks into your clinic. You're sitting on your office, and he cannot feel any pain or temperature in his right side of the face, right side of his face. He also cannot move his right eye, blink or smile, right side. He feels dizzy sometimes and gets nausea. He also has ptosis and dryness in the right eye. Someone already got it. Okay. If you didn't get it, think about it and tell me. You see, it's easy now. Okay, I'll give you another example. So this is lateral pons or lateral pontine syndrome, what I just said. Okay, I'll give you another example. Patient walks in, quadriplegia. He cannot, when you did the eye test, he cannot move his eye laterally. And he has some sensation defect on his right side of the face, which medial pons, there you go, medial pontine syndrome. That's absolutely correct. A guy comes in, he protruded his tongue, okay, and it deviated. He also have hemiplegia, right? And he cannot feel vibration or proprioception. But this patient asks you, which artery, doctor, I have defect in? Which artery did got stroke? He just randomly asks you this. Okay. Guy comes in. Guy comes in. He cannot speak, he cannot swallow, and he cannot feel temperature or pain on his one side of the body. He also struggles to move his neck. Pika. You guys covered every single defect. There is nothing that can beat you in the exam. I really, really hope you get all the brainstem lesion questions correct. That's it. Literally, that's it. Now you just play with it by yourself. One essay. Because I said this guy cannot feel pain, temperature, and he cannot move his neck. So 11, right? 11, pain, temperature, that's the spinothalamic tract. And I said he cannot swallow or speak properly. 9 and 10. So look at the cranial nerves. Which one is it? Pica, right? Pica syndrome or lateral medullary syndrome. Okay, amazing, amazing. Now we learned this amazing rule. Let me get rid of it. So now, when you look at this picture, it will make sense to you. You just play with it. But of course, cranial nerve 8 is like in the middle, and then you have like cranial nerve, sorry, 7, and then 8 and 5 are like between. These details are, this is fine tuning. But the main idea, main presentation, خلاص, you get it. Using this way. Very easy, very simple. I hope it made it really clear. Okay, let's go back to the presentation. Right. Yalla, answer. I'm not gonna say anything. I'm not gonna explain. You have to answer, and someone need to explain to me why. Why? Why did you say B? Why did you say B? Give me the hint. I trust you guys. You know what? I trust you guys. I know you understand. But you do, right? I'm gonna trust your word. Hypoglossal medial medulla, right? Hypoglossal is in medial medulla, and it fell to the right. So this means the left side is contracting, the right side is not contracting. Because when you contract the left side without the right, it will go like this. See, I'm contracting this only. So right medial medulla. Good job, sir. Good job. Answer. When looking to the left. Now here it's not brainstem, it's a cranial nerve. If you know the cranial nerves. What do you guys say? MashaAllah. Perfect. Individual experiences ipsilateral paralysis of the soft palate and pharynx. He has hoarseness, dysphagia. Wow. And carotid sinus reflex is lost. This is a giveaway, by the way. This question is a giveaway. It's a giveaway. Like once I said carotid sinus reflex, it's a giveaway. All of it. Good job, guys. I'm proud of you all. MashaAllah. Cannot smile, left side, muscles affected, eyes open, he can't close them. Okay, which nucleus is this first? Which nucleus is this? Before we jump into the conclusion, which nucleus is this? Think again. Is it trigeminal? Trigeminal is sensory or motor? Facial. Why facial? Because he cannot open his eye. That's right. Trigeminal is mostly sensory. This is trigeminal because he cannot open his eye. He cannot smile. Okay. And where is the facial located? Remember the map. Where is the facial located? Now, we know it's in pons, right? We know it's in pons. That we know for a fact. But is it upper or lower? No, it's in lateral pons, yes, but upper or lower? Now, I'm not sure if they will ask you, but I saw in Dr. Yaqeen's slide, he does differentiate between upper and lower pons. And it tells you when you go down, you find the facial nerve, not when you go up. So this should be lower pons. And remember, guys, the picture I showed you, facial nerve was actually a bit down between the pons and medulla. But yes, it's in pons, but lower. So I'm not really sure if they will ask you in the exam about upper and lower levels of medulla and pons and midbrain. But in Dr. Yaqeen's slide, I saw them and he did like differentiate and told you this is upper, this is lower, this is upper, this is lower. He even divided, I think, upper, middle, lower or something. Like he went deep into them. So just know them in case, okay? Know them in case. Okay. Stroke, damage the right side, right cerebral, sorry, peduncle, left side motor loss. What will also happen? Something will also happen. What is it? First of all, what does he have? This patient. He has something. What is it? Cerebral peduncles, guys. Remember. Okay, he has paralysis, right? He does have paralysis. He already told you, like, look, to close proximity of a cranial nerve to the cerebral peduncles. So in the midbrain, cerebral peduncles are in the midbrain. What cranial nerves are is the midbrain already? There are two nucleus in the midbrain, two cranial nerves, because cerebral peduncles. What are they? Three and four, right? So what do you think will happen? Three and four. So what do you think will happen when this closed nerve of the cerebral peduncle is affected? What will happen? What control will he lose? Visual acuity is not really by the nerve, visual acuity, like if he can see or not. It's a motor control, right? It's a motor control. If he will control the muscles in his eye, visual acuity is not really related to the nerve, but it's a motor control of the right eyes. Okay. Uh, may you please pause the recording for 2 minutes? I just need to check on something and I can be back. Is that fine? Okay, so next question. Difficulty swallowing. What do you guys think? Lateral medullary syndrome. And why is that? Why? 9 and 10. Does everyone agree? Does everyone agree that it's lateral medullary syndrome because it's kind of 9 and 10, and left side because, well, and 7. Yes, and 7. That's right. Absolutely. Next question. I'm gonna read out the symptoms, okay? I'm gonna read out the symptoms and then we'll choose the answer together. So dizziness. Dizziness. Which cranial nerve is dizziness, guys? This is important to know. 8. Okay. Unable to move her right eye medially. Medially. So which cranial nerve is this? Medially. 3. Locus of the region. What is it? Well, I think this question is wrong. Wow. 3 and 8. That's a stretch. What do you guys think? Hmm. Yes. E. Why E? Well, if you just look at right eye medially, the only place it's found is in the midbrain. Dizziness, they didn't say it was the problem, like the main presentation. Now, it's a bit tricky, right? It's a bit tricky, but like you shouldn't fall for this in the exam. You have to be careful. Like several days later, they found the patient unable to move the right eye. So something happened. Something happened now. A lesion happened after. It could be related, it could be not. I was hesitant at first to put this question, but I was like, let me put it just in case. Well, for me, if I was choosing questions for you guys, this is a bad question, okay? For me, it's a bad question, but you don't know what to expect, Al Faisal, You can get questions you don't really like, so. Okay, this question is actually from Ambus. This is from Ambus. So tell me what you think. Without looking at the picture, tell me what he has. Just tell me what does he have. And then look at the picture and tell me why. Okay, let me read the question now. Right-sided body weakness. So now you know it's in the left side, right? Because right side body weakness, contralateral. You know this. Tongue protrudes to the left. Again, the left side, defect. Now from these two only, motor and tongue, that's medial medulla. But we can continue. Vibration, again, medial lemniscus, that's medial medulla. Muscle, plantar, this is upper motor, yeah, these three. This is exactly typical presentation of medial medullary syndrome. And you're right, my friend, it's F. That's absolutely correct. So if you can see here, this is a nice image showing you. You can get them from Ambos. There's like for every section. You can see this is the hypoglossal nerve, and this is what this pyramidal tract or like the motor. And then you have like this is the olive. Through here also passes the medial lemniscus, the MLF. So good job, good job. Okay, I'm gonna read the symptoms again because I don't wanna waste much time. So pain behind the ear, paralysis of the right side of the face. This is highlight. So right side of the face paralyzed. Taste sensation, right? We can't. So what does that mean? Facial nerve, right? Facial nerve. Increase sensitivity to sounds. Everything else is normal. So the patient will also develop what? So now you know it's a facial nerve problem. Do you agree? What can this patient also present with? Remember, what does the facial nerve do? Dryness. Why dryness? And why the right eye? Right eye because it's in the ipsilateral side, right? We said it's a right side problem. Right side of tongue is not sensing the taste. And remember the gland in the eye, right? So dryness. Good job. Superior synaptic nucleus as well. We had a question for this in the beginning. Good job, my friend. Good job. So let us see. Medial medullary syndrome. Oh, we talked about this so much time. Now you guys should be pros in this. If you get a question about any lesion in the brainstem and don't get it wrong, and after you watch this, I'm gonna be sad. Don't make me sad. This is very easy now for you. Correct, mashallah. Very good job. Branch of the vertebral artery. Remember ASA. Remember ASA. Do you remember anterior spinal artery? There you go. This is it. Medial medullary syndrome, ASA. You see this table that I showed you? Memorize it by heart. Or instead of memorizing it, understand how it happens, draw it, and you will find that automatically by just closing your eyes, you will see the best map of your life. Trust me, it's better than anything. Okay. Paramedian infarction of the base of pons. Base of pons. What do you find there? What do you have in the base of pons? Do you have the trapezoid body there? Are you sure? What is the trapezoid body? What's the trapezoid body? Trapezoid body is actually, I think, found in the sides because it's a body for like some sensory. I'm not sure because I haven't went through the trapezoid body, but remember the image. What runs in the middle? The cortico spinal tract, the motor. So pyramid, the pyramid tract or the corticospinal or the motor tract, all of them they're the same thing. So yes, see, my friend, absolutely. Leg dystaxia, nystagmus, hoarseness, mitosis, and ptosis. Meiosis, sorry, and ptosis. What's this guy problem? So once you see vocal cord hoarseness, you just automatically know the answer. It's like a giveaway, honestly. What do you guys think? What do you guys think? Good job. Good job, you guys. Proud of you. Proud of you. Amazing. Well done. Okay, now we moved into the cerebrum, it seems. Okay. Okay. Let's go through this real quick. Okay, so cerebral infarction. Speech is not really good. He cannot write, but he can understand. I'll tell you something very nice when once we finish about Wernicke's and Broca. Okay, B, right frontal lobe. Okay, why? Which area is this? First, which area is this? We're thinking Wernicke's or Broca. Okay, Broca's area. You're right, but it's left because he has lower facial weakness on the right side. Your right is the frontal, but it's just left and right. Okay, it is a double question. Okay, the first thing, Broca. Guys, look, we argued about this, I remember in second year about Broca's and Wernicke's. Just understand this. Broca is more like you can't do something, but you can understand. Wernicke's, because it's close to the temporal, it's like, remember, temporal is about how you think, how you imagine and all this stuff, the not really action stuff. So Wernicke's, you can't understand, you can't comprehend, you don't know what's happening. You can speak though, but you just can't speak properly, but your motor is functional. Broca, he cannot speak, but he can understand. Like he knows what the words are, like what's happening, but he just can't speak them out. Now, frontal lobe, it is in the frontal lobe, Broca. Right or left? We said he has lower facial weakness on the right side. And remember the picture, guys. Actually, let me show you the picture. I have a very beautiful picture for you guys. Let me see. Is this? No, it's not. I think it's in the. It's called some nerve. Oh, I can't see from this. CN lesions. There you go. So look at this. Remember this, guys. Can you see? When it's an upper motor neuron from this side, look what happens to the other side. Just keep this in mind. You want to take a screenshot, feel free to do so. But keep this in mind. By the way, USMLE summaries are really nice. Like, look at this. Really nice. This is really nice as well. They give you sometimes also like nice mnemonics. I advise you go over it if you study. So we know now the answer. We know the problem. We know what's happening. Let's go next. Headache. Drift. Hemiparesis. Turn to the left side, papillema, and the region of north like which of the following. Yeah. So what type of problem is this guy having? What type of problem is he having? Motor, sensory, what type of problem? Eye, ear, occipital. You said occipital. Why occipital? What does the occipital lobe do? What does it do? Vision. Okay. Okay. Are you sure? Hemiparesis though. Occipital hemiparesis. He didn't say he has uh, heminopia, hemiparesis. It's different. Hey, frontal. So guys, let me show you something. I'm showing you a lot of things today because we really need to know a lot of this stuff, but let me show you something really cool. Is this the one? Oh no, this is not. Okay, see these? Know them like your name. See how you know them? Know this like this. So premotor cortex. You know that frontal is for what? See, frontal eye field, even like there is control. Here it's for vision. So if you're seeing like things, no, normally you don't see like half blacked out, half something, you know, it's from here. But motor problems are all in the frontal. This is parietal. Parietal, what did you say about parietal? Sensory. So sensory association cortex. Porotemporal, limbic, so feelings and stuff. You know, Wernicke, right? Temporal Wernicke. Auditory for, so know them really well. Let me see if I have something else to help you with this. I have something that I wanted to show you as well. It's the homunculus. The homunculus. See the frontal lobe, but this is, we didn't have a question about this yet. Let's have a question about this yet, and I'll explain to you. Okay? Do you guys get it? Why the frontal lobe? Because of the motor. Okay. Paralysis of left arm and leg, and proprioception, and vibration. Which of the following is a problem? Remember, I just showed you the picture of the brain, so you have to know now. It's not E. It's not D. And it's not C. Is it B or A? Did you say A now? Oh yeah, someone said A. It's B. Why? Remember, somatosensory cortex. So, vibration, and the primary motor. Primary motor because he has paralysis. Let's go back to the picture again. What is it? You need to really know the brain functions. Why do I keep opening this picture? You need to know the brain functions. Where did it go? So look. See, he's probably having somewhere right here, the central sulcus. Behind that is more sensory. There is still motor and some vibration. Now, in Dr. Aka's lecture, like he tells you exactly every presentation, how does it look like, and every disease. So make sure to go over those. Okay? Make sure to know exactly which part of the brain is affected and when and what does it present as. This is a very important topic, by the way. Okay, numbness and weakness in the left leg and foot. Which of the following artery is this? Now, this is the homunculus I'm talking about. This is, you need to know the homunculus to know what's happening here. Why A, my friend? Why did you say A? Okay, you both said A, actually. And it's correct. So let me just go through the homunculus, okay? So that, because this is very important. Lower limb by anterior cerebral, yes. Lower limb by the anterior, yes. And then upper limb and then the face is by the middle. The posterior cerebral, it goes down to the brainstem. So posterior cerebral will have brainstem manifestation and some, you know, lower lobe manifestation, not lower lobe like the posterior lobe. The middle cerebral will always present with the upper, you know, motor neuron, upper like limb problem, facial problem, sensory and motor. The anterior typical presentation you will find is lower limb problem, lower limb sensation, numbness, lower limb motor problem, like this one. Let's see this one now. Let's see if you guys can answer this. Unable to move his left leg or arm. Oh, both. Can't move the eye immediately. Sounds familiar. So what do you guys think? So we know it's not anterior cerebral artery because arm is involved. And we know it's not the middle cerebral artery because the leg is involved. So we eliminated A and B, right? Superior cerebellar, no. Why? Because there is no cerebellar problems. Superior cerebral supplies the cerebellum and he will show balance problems. There is no balance problem. Pica is not pica. Why not pica? Why not pica? Remember, pica is lateral medullary syndrome. This does not look like lateral medullary syndrome. And remember, I told you the posterior cerebral artery, it looks like a brainstem lesion, mixed a little bit with the anterior and middle cerebral artery lesions. So it's like a mix of everything, the posterior cerebral artery, right? He has upper unable to move leg, arm, everything. Why? Because they go down from there. And this is where the posterior cerebral artery sits. Remember what supplies the midbrain as well. So everything goes from the midbrain, literally. This is why it's dangerous. You guys got this? Did you get it? Perfect. Perfect. Okay. Someone had a stroke. Speaking and swallowing. Sensation of pain and temperature right side of the body. And vertigo. Let's go to them one by one. Speaking, swallowing, 9 and 10. Sensation, pain, spinothalamic tract. Vertigo, 8. Where do these fall? Where do they fall? Remember the map. Where do they fall? 8, right here. Somato, right here. What does that other stuff? 9 and 10, right here. So this is a Pica syndrome, lateral medullary syndrome, right? Correct, my friend. Oh, we're done. We're done. So please scan the QR code. This is from GND to give feedback. And if you have any questions about anything I discussed earlier, please ask me. Vertigo isn't lateral pons. Okay, look, vertigo is lateral pons, but as I told you, the fine tuning, look, it's like between, it's like in lateral pons, yes, but it also goes there. So it's like between. C5, it's like between. They're mainly here, but like they can share sometimes, no problem. And even like, for example, the facial, it's between medial lateral, but when we use the rule of fours, we divide them and then we do the fine tuning after practice. But as beginner, but I'm sure you're all pros, mashallah. You answered almost every question correctly. So you're all pros. This, you need to know how to draw it. I'm not saying you to be an artist. You just need to know how to function it in your head and how to utilize it. It will help you lots in the exam. This, you need it. What else do I have? Yeah, this, know it very well, guys. Open any picture summarizing every single lobe, every single Brodmann area. You have Brodmann area like 8, you have 44, 45, you have the single, you have a lot of Brodmann areas, okay? Know the ones that Dr. Akif covered, and know Wernicke's and Broca's very well, and know how they present. Know the difference as well. And I told you the difference. What else do I have? You see these pictures? Not this, wait. Yeah, this. So the medulla, know it. But I already showed you like a way to know, but no, you need to know how it looks like in case you got something, but I don't think you will get any pictures, honestly. So this is just for information, like mostly. Let me see. This is important, I think. Yes, this is very important, guys. You need to know each artery where it goes because you will get a lot of questions about strokes in the arteries and what do they supply and how. Like, look at the course of each artery, if you notice. So now you can imagine which part of the brain, instead of just memorizing, you understand how the brain works, how the arteries go, how do they communicate, and all that stuff. This is really important for you. Let me see if there is anything. Yeah, this is also nice to know the distribution of each artery. So, for example, anterior artery has a stroke, so this is part of the brain. These areas, when I told you middle cerebral, it's this area. So Broca's is middle cerebral, for example. Keep them in mind. These are important. Nice, nice stuff. And that's it. Please scan the QR code. And if you have any questions, don't hesitate to reach out. Thank you so much. And wish you guys all the best in your exam, inshallah. My colleague Lena will cover everything else. Like I covered from brainstem, cerebral, and blood supply. My colleague Lena, she will cover everything you took before that. So I'll leave you guys with the GND and Lena. Please allow me. And thank you so much again. وجود luck on your exam. الله يوفقكم يا رب. السلام عليكم.
My screen first. Okay. Bismillah. Okay. So, my name is Leena. I'm a second year medical student with you guys. Inshallah, I'll be hosting the or doing the PAL session for the first, I think, 8 lectures. So we will be going over the introduction of the neuroanatomy. We're gonna be going over yeah, for sure. Yes, yes, okay. We'll definitely, okay. So let's have a 5 minute break, and then I'll go ahead and start at 8. Do you want a 5 or 10 minutes break? Because I completely understand if you want a 10 minute break. Just let me know. What do you think, 10 or 5? 10 minute break. Okay. So we can stop the recording and start at 8:15 sharp, okay? I'll see you then. Okay, so I'm a second year medical student with you guys, and inshallah, I'll be doing the first half of anatomy, as I said. So we're gonna do the general anatomy introduction, and then we're gonna do embryology, and then we're gonna do cellular composition of nervous system, and then we're gonna mix up all the spinal cord questions together because they're all interconnected, and then we're gonna do peripheral nerve injuries, which is kind of all MSK in one lecture, inshallah. So just a little introduction, and like my biggest advice of this whole like PAL session is that please study smart, not hard. And the reason I say this is because I highly recommend first using tables, using people's summaries. Like it's great. Don't be so pressed about doing it yourself because it's very hard to do everything yourself and everything perfectly. So this is basically me telling you guys that a lot of the presentation when I referred to like to explain certain things about each question, I actually referred to some tables and summaries that our peer colleagues in our batch did because it's like that's smart. Like I don't need to be wasting time making it myself when it's already ready. So full credit to our amazing batch notes that we get because a lot of my references are from them. So I really want to say a shout out to Muhammad and Marwa's notes because they saved me in studying and in preparing for this presentation. So, and another thing I want to mention about studying smart and not hard is basically my approach for this whole presentation, which is basically that every time I get a question, I dissect it and I go back to the lecture that explains it. And I'm going to show you an example here is because I have a question here and then I'm going to explain the exact picture that comes from the slide. And this way you're able to answer every question from that specific slide and not necessarily if the question comes exactly repeated or exactly the same way. And that's how you gain more knowledge and that's why you have more comprehensive revision. And that's what I recommend you do is sometimes when you don't have time, go solve questions and refer back to the lecture as revision. So this is going to be my whole approach for the presentation. And again, like as I am a student as you guys are, so apologies if I make any mistakes. Please don't hesitate to correct me. Please don't hesitate to come back to me later and be like, oh, Lina, you made this mistake because I am as human and as much of a student as you guys are, although I try my best to make this correct. And another thing that I want you guys to know is that all my questions are from resources. So inshallah, the questions should 100% be written correctly and the answers should be 100%. I didn't make any questions to refrain from that problem. So I apologize if you saw these questions before because at the end of the day, there's no better way to get questions but from books and like actual references that I can make sure that I'm giving you guys a correct comprehensive explanation. Okay, so despite that, I know I talked a lot of an intro, a long intro, so let's go ahead and start. So as we know, the first lecture is organization of the nervous system, so that's going to be just some random information. So does anyone want to solve this question or read it out loud, or do you guys want me to just go ahead and read it myself and then you guys can answer in the chat? Okay, how about we go over I read it, and then you guys can answer. Okay, so in which of the following CSF can be found? As Rudaina said, it's A, subarachnoid matter. And if we go back to exactly, you guys are right. And if we go back to this picture, we can see what are the layers. So first, we have the scalp, and then we have loose connective tissue and pericranium. Then we have the skull and the clavaria, and then the uppermost meninges layer is the dura mater. Then we have the arachnoid matter, subarachnoid, and then pia mater. And the CSF is located between the arachnoid matter and the pia mater, which is called the subarachnoid space, or under the arachnoid. So sub meaning under the arachnoid space. So and in the arachnoid space, we have something called arachnoid granulation villi. And these arachnoid granulation villi take the fluid from the subarachnoid space and give it out to the venous drainage, which is the venous drainage of the brain. So the CSF can actually leave out, and we don't have high blood pressure or high pressure of the CSF, sorry. Okay, so again, I'm going to repeat the same concept again. We have the scalp, we have loose connective tissue and pericranium, we have skull cap, we have dura mater, arachnoid mater, subarachnoid, pia mater. And the pia mater is very much stuck to the brain. It's basically part of the brain where you can't really remove it from the brain tissue. And again, the arachnoid has arachnoid villi that is able to drain the CSF to the veins. If the meningeal artery ruptures, which of the following will occur? Subarachnoid hematoma, epidural hematoma, subdural hematoma, or extradural hematoma? Okay, so we have a bit of a mixed answer. So the correct answer is actually extradural hematoma. Epidural is under the dura, extradural is above the dura. Okay, so the answer is going to be D, it's extradural. And the reason why is because, oh, sorry. Oh, I think there's a mistake, because epidural, I just realized now, epidural and extradural, I think have the same meaning. So the answer is going to be extradural or epidural. I apologize for that, because epidural is literally the same as extradural. So you're completely correct, Hiba. And so basically a torn middle meningeal artery. So this is the meningeal artery, and we can see that it's right before or above the dura mater, and the skull, for example, fractures. So you'll, for example, have a case where, oh, someone fractured their skull. Middle meningeal artery ruptures, and then you have a epidural or extradural hematoma. The concept is it's above the dura. And then how about how you get it subdura? How do you get it under the dura? It's if you have the torn bridging veins. So over here you have veins that are actually draining the CSF, exactly how I explained. You have them here. And so if they get torn, called the bridging veins, you will have a subdural hematoma, which is usually very slowly expanding. On the other hand, the epidural hematoma, you'll see rapid hematoma. So you're going to see an acute versus a late kind of onset. And for the torn bridging veins, just know that they are from the superior sagittal sinus, which makes sense, okay? Does anyone have any questions about this? Is it clear? And do you guys get how why epidural and extradural is the same meaning, right? You know, guys, why that is. Okay, yes, okay, great. So if the superficial veins get injured, which of the following hematomas will occur? So the word is superficial cerebral veins. So it's basically the same meaning as bridging veins. So the answer would be subdural hematoma. Okay. So that would be basically this part that I just explained. The torn bridging veins. Okay, it will be this. Is it clear? I'm just gonna try to give off the laser pointer options. Oh, clear, and then, Okay, I'm glad it's clear. So we'll go to the next. Which of the following correct order of the meningeal membrane is the outer to most to innermost? So outer to most inner is dura, arachnoid, and then pia. Great, B, exactly. I want you guys to tell me what type of fibers. So this is a picture of different types of fibers in the brain. I want you guys to tell me the name of the fibers, and I'm gonna remove this icon and you're gonna be able to see it. And if there's an example for each one, I want you guys to tell me the example of that type of fiber. So what about the first picture? What is it called? Second picture, what is it called? Third picture, what is it called? And fourth picture. And I want examples specifically for the third, fourth, and fifth picture. Okay, so short association fibers, yes. And then long association fibers. Great. And then we have the commissural fibers. And then we have the last one is the projection fibers. Okay, perfect. So we have short association fibers, long association fibers, commissural fibers, and then we have the projection fibers. So for the short association fibers, it connects short distances in the same hemisphere. Okay, it's in the same hemisphere. Association fibers both connect in the same hemisphere, but in short, it's short distances from between a sulcus and a between a sulcus and gyrus, you know, like, so you're connecting two areas next to each other, two bumps together. On the other hand, the long association fibers is connecting one cerebrum, the cerebrum from one cerebral hemisphere, but it takes from all the way, like kind of like a circle from the back, as you can see over here. And the commissural fibers connects the right and the left hemisphere together. And then we have the projection fibers, which brings information up and down, like the ascending tracks and the descending tracks. What's an example of a long association fiber? Like the cingulum. What's an example of the commissural fibers? It's the corpus callosum. And what's an example of the projection fibers? We have an ascending and descending tracks. Give me an example of a descending track and an example of an ascending track. At this point, you guys think this is common sense, right? So obviously, an example of an ascending track would be a sensory track, which, for example, spinothalamic. And then if you have a descending track, you have corticospinal. Okay, perfect. So let's go off to embryology now. A 29-year-old woman comes to the physician because of poor balance and recurrent falls for the past month. She also has blurry vision in her right eye for the past 2 weeks. She reports worsening of her symptoms after taking a warm bath. Physical examination showed generalized hyperreflexia and intention tremor. Romberg sign is positive. Visual acuity is 20/50 in the left eye and 20/100 in the right eye, and she is unable to distinguish red from green color. The cells primarily affected by this patient's condition are most likely derived from which of the following embryological sectors. So let's identify what's the cell that would cause, if you lose it, would cause hyperreflexia, intention tremor. Like what's the cell? What's the cell? It's a neuron. So the answer would be like neurons. What are neurons from? So they're neuroectoderm. Okay, so they are made up of the neuroectoderm. So the answer is C, correct? Okay, so I wanted to review all the derivatives. Where did each come from? Because although sometimes we always think the answer is ectoderm, actually that's very vague. So I want to talk about what are the derivatives of the notochord, what are the derivatives of the neural crest cells, and what are the derivatives where, like, what the nervous system as a whole is made up of. So as the question said, the nervous system is made up of the ectoderm or the neuroectoderm, which turns into the neuroectoderm at third week of embryonic life and almost finishes by the fourth week almost. Okay, that's a generalization. 4 to 6 weeks. So as we said, it's generally the neuroectoderm. But what about the notochord? The notochord induces the ectoderm to turn into a neuroectoderm. So what induces the ectoderm to turn into a neural ectoderm? It's the notochord. And then from the neuroectoderm, it forms the neural plate. Okay, so ectoderm turns into neuroectoderm, turns into neural plate by the notochord. What else does the notochord form? It induces the formation of vertebral body of each vertebrae. So each vertebrae, guys, comes from the notochord or is induced by the notochord. The third thing that you have to know that the notochord does is that the remnant of the notochord in our body, embryologically, if they say, what's the embryological remnant of the notochord in our body? It's the nucleus pulposus. This is part of this disc, the discs between the vertebral bodies. There's a nucleus pulpus and annulus fibrosus. Nucleus pulposus, this is a remnant of the notochord. It forms the nucleus pulpus of the intervertebral disc. So again, three things. It induces ectoderm to turn into neuroectoderm. It induces the formation of vertebral body of each vertebrae. And the remnant of the notochord is the nucleus pulposus of the intervertebral disc. So this is the notochord. The neural crest cells, you have to know that it gives five very important things. And most importantly, you should know the things in blue because that's what's relevant for us. But actually, you have to know all of them. Number one, it creates the neural ganglia of the dorsal root, the sympathetic and parasympathetic. So it gives off the dorsal root ganglia, sympathetic ganglia, and parasympathetic ganglia. And what's the dorsal root? It gives off the sensory. So technically, sensory ganglia. Okay, so I want you guys to memorize this. Dorsal root, sympathetic and parasympathetic ganglia. Then you have the adrenal medulla, you have the Schwann cells, melanocytes, and leptomeninges. What's leptomeninges? It's basically the meninges that make the pia mater and the arachnoid matter. So dura mater is not created from the neural crest cells, okay? So again, neural crest cells make the neural ganglia of the dorsal root, the sympathetic, and the parasympathetic ganglia. Second, adrenal medulla. Third, Schwann cells. Fourth, melanocytes. And fifth is leptomeninges. What are leptomeninges? Pia mater and arachnoid matter. Dura mater is not a derivative derived from the neural crest cell, okay? Okay, so a newborn has multiple congenital defects due to dysgenesis of the neural crest cells. Which of the following cells is most likely spared? So what's the keyword here, guys? Just tell me the keyword. What's the keyword? What's the keyword? The keyword is spared. So the word spared makes a whole difference because I don't want you guys to get confused. What's spared is what's left. So what's left is the motor neurons because we said it does the dorsal ganglia, not the dorsal. It does melanocytes, parafollicular. It does geniculate body, which is sensory, dorsal root ganglia, which is sensory. Okay? So the answer is D. Okay, the neural retina is derived from the Okay, it's from the neural crest cell as well. Okay. The neuroepithelium leads to the development of development of which of the following cells except for the neuroepithelium? Anyone know this answer? Okay, so for this question, the neuroepithelial cells that lead to the development of the following cells, except it does not turn microglia. Microglia. So let me explain why, because I'm sure you forgot this. It's okay, and that's why I'm doing this PAL session. So it's microglia, and because microglia cells develop from the mesenchymal cells and not from neuroectoderm or neuroepithelium, and they are actually similar to macrophages. They eat up basically, they're the housekeepers of the nervous system. They clean up debris, they clean up everything, any debris. So it's actually part of the mesenchymal cells, and then it gets trapped, as they say, it gets trapped in the nervous system. So it's one of the cells, cells in the nervous system that is not created from the neuroepithelium. It's created from the mesenchymal cells, okay? A child is born with a cyst-like protrusion from her lower back. In order to determine the seriousness of this development defect, an MRI of the structure is viewed. The spinal cord is observed in the correct position, and only in the dura mater expansion is found in the structure This is a anyone here to answer? I'll give you guys half a minute. Okay. Does anyone else think it's C? Okay, exactly. So the answer is C, because there's only dura mater. There's no nerves involved. There's no spinal cord involved. If it's meningomyelocele, it's going to be the spinal cord involved. And I'm going to show you here the pictures of the different neural tube defects. We had 6, exactly in the lecture, we have 6 neural tube defects that we have to know. 3 are in the cranial part, and the bottom part of your body, or the level where the spinal cord is, we have 3 as well. So in terms of the spinal cord, we have 3. One is the spina bifida oculata, which is everything is in place. The spinal cord is in place, everything, but it's not closed in the back properly. So you have this hair in the back indicating that it wasn't completely closed at birth. So this is the one that sometimes there wouldn't be any complications. So it's actually like the best case scenario. So it's closed, it's not completely closed. This is spina bifida oculata. Meningocele is when there's a protrusion of the meninges. So the meninges are actually protruding, but there is no nerves inside. There is no spinal cord inside. So protrusion of the meninges, and it's filled with CSF through the defect in the skull or the spine. And then you have myelomeningocele. Myelomeningocele, which is the most severe situation of the spinal cord, when the spinal cord is actually protruding outwards. It's not closed. There's CSF, there's meninges, and there's actual nerves inside that cyst. So obviously, this is the worst situation. Then you have the types where it's like from the top. We have cranioarthritis. I don't know how to pronounce it, but basically when the brain is completely open as well as the spinal cord. So this is like not compatible with life. The baby usually dies in utero or as a stillbirth, where the brain and the spinal cord as a whole is not open. On the other hand, encephalopathy is when the brain is open, but the spinal cord is closed, and it's still not compatible with life. And then encephalocele is when the brain and the meninges is herniated at a certain point, where it's creating this cyst-like structure. Okay, but this happens in the brain. So again, I want you guys to remember these neural tube defects and remember these 6 types. And remember that cranioankylosis is when it's completely open brain and spinal cord, and it's the most severe types of neural tube defect, and it's not compatible with life. Okay? Okay, let's see this question. It says, a female neonate is noted at birth to have a gross deformity of her lower back. Examination of the subcutaneous lesions reveals disorganization of neural tube entrapped of nerve roots. Which one is the appropriate diagnosis? Exactly. It's meningomyocele because it involves the meninges and the nerve roots and nerve tissue. Why is it not meningocele? Because there's entrapped nerve roots. Meningocele has no nerves. It only has meninges and CSF. Rachisises, or whatever this is, number C, is open brain, open spinal cord, not compatible with life. Spina bifida oculata, what is it, guys? We said that it is when it's not completely closed, but there's no cyst and there's no CSF and there's no problem at all. It's just not completely closed, and you're gonna see this tufted thing in the back with hair. Okay, and then you have syringomyelia, which is just something very in spinal cord lesion, so it's not involved. Okay, clear? Great. So the answer is B. Again, I wanted to show you guys how a lot of questions can come differently, but the same slide gives you the answer. And that's why I do this way in studying. Which of the following structures are formed from the procephalon and becomes the two cerebral hemispheres and the basal ganglia? Mesencephalon. Let's have another try. Okay, A. Anyone else want to participate? Okay. We're between A and D. Let's see. So the answer is D, actually, and the reason why is let me show you here. Yes. So this picture. So we have the forebrain, midbrain, and hindbrain. These are the three primary vesicles embryologically. And then each one divides into two. The forebrain becomes the telecephalon and the dicephalon. And the midbrain becomes the mesencephalon, and the hindbrain become the metencephalon and myelencephalon. And I apologize for pronouncing things wrong. I'm not the best at pronouncing them. So the forebrain telecephalon makes the cerebral hemisphere and the basal ganglia and creates the lateral ventricle. The forebrain also divides into dicephalon. The dicephalon has all the letters thalamus, all the words thalamus, thalamus, hypothalamus, epithalamus, subthalamus, plus retina and optic nerve. Thalamus, thalamus, thalamus. And again, letter T, third ventricle. Okay, so dicephalon is all about T's. Okay, it loves the letter T and it loves the thalamus. But don't confuse it with telecephalon. Telecephalon is the cerebral hemisphere. And the way I remember it is is telephone. So when you put the telephone, you put it on your brain like this. You put the telephone here on the brain. So cerebral hemispheres. And you put it laterally. So you put it on the lateral ventricle. And then dicephalon, I always think of it for brain, is telecephalon and dicephalon. Telecephalon because it's the telephone, and dicephalon is because you have to dial the numbers. Okay, so you dial the numbers. And then when you dial the number, you dial the number 3. Okay, so I hope that helps you memorize. When you dial, you put it number 3. And then you have the midbrain. The midbrain likes the letter M. Midbrain for mesencephalon and midbrain. Midbrain. So it makes the midbrain, which is part of the brainstem, and the ventricle it creates is the cerebral aqueduct. And the reason why I'm going over this, guys, is because the doctor really stressed on it. He said this picture is so important. So I don't want you to guys to miss a question on a pure memorization question. So try to memorize it with me. Hindbrain, which is metencephalon and myelencephalon. Metencephalon makes the pons and the cerebellum, and the myelencephalon makes the medulla. And then the hindgut as a whole creates the fourth ventricle. And always remember it by order, guys. All of this is going by order. The forebrain is in the top, the midbrain goes in the middle, hindbrain goes in the bottom, and you're really going by from cerebral hemisphere all the way to the medulla, which is the bottom part of the kind of like the brain or CNS structure. And the ventricles are as well. You're going from lateral to third to cerebral aqueduct to fourth ventricle, and then the central canal. So you're going memorize it by how you organize it in your brain. Okay. Why are the low end? We didn't solve this question. I'm gonna remove it. Why are the lower limbs specifically affected in spina bifida with meningomyositis, guys? Yeah, B. Okay, but can you explain to me why? Like, why do you think, why is it B? Guys, go ahead and unmute. Like it's like maybe it's much easier for you guys in the chat if you'd like, يعني. No one? Okay, it's okay. I'll say it. So why are the lower limbs specifically affected in the spina bifida with meningomyosile? Because meningomyosile involves both the dura and the nerves. So it's the spinal cord of the cardiac quina, which is nerves at the end of the nerves, basically, the end nerves. The lack of the brain development not involved in spina bifida with meningomyosile because the brain is for like other diseases, not specifically spina bifida, spina from the word spinal cord. Presence of excess amniotic fluid, no. Hyaluronic acid deficiency in the lower spine, no. Okay, so the answer is B. What is the name of the cavity inside the dicephalon? Don't forget what you dial the phone. Which number do you put? It's B. Good job. So let's think of it. Lateral ventricle for which one? For telecephalon. Third ventricles for dicephalon, which are for the forebrain. Then we have the cerebral aqueduct, which is for the hindbrain and the mesencephalon, I think. Fourth ventricle, it's for the hindbrain. Sorry, that was for the midbrain, for the mesencephalon. And then the last one, which is the fourth ventricle over here, is for the metencephalon and myelencephalon, which create the fourth ventricle. Okay, so B is the answer. Which vitamin was taken excessively during pregnancy can contribute to neural tube defects? Yeah, so it's C. I think this is something we know from first year. It's vitamin A, but just like as a reminder, valproic acid, which is an anti-epileptic or anti-convulsive therapy, is considered contraindicated in pregnancy because it causes neural tube defect, hypothermia and hyperthermia, so excess heat, excess cold, and excess vitamin A. And if you have hyaluronate deficiency, it can cause neural tube defects because it's important in creating the basement membrane and dividing the neuroepithelium. Okay, so these are the 5 things that would put you in risk for neural tube defects: valproic acid, hypothermia, hyperthermia, excess vitamin A, and hyaluronate deficiency. What can prevent neural tube defects? Folic acid. Okay. Which factor is not commonly associated with causing neural tube defect? C. Good job. Which of the following statements best describes the sulcus limitans? Honestly, yeah, good job for knowing Yusuf. Good job. But honestly, like this is the part of embryology that I usually ignore, but you can't really do that. So this is kind of a revision of where this comes from. So this comes from the growth factors of the ventral part of the neural tube and the dorsal part of the neural tube. Obviously, we have a front and a back part of the neural tube. The front part, or the ventral part of the neural tube, is influenced by the sonic hedgehog gene, SHH gene, and the dorsal is influenced by the bone morphogenic protein, BMP. Okay, so the ventral is SHH and the dorsal is the BMP. Okay, and so what's the ventral made up of? It's made up of the floor and the basal plate. On the other hand, the back is made up of the roof plate and the adder plate. what separates the ventral from the dorsal? Sulcus limitans. And what is it? It separates the sulcus limitans, separates the alar plate from the basal plate. So you're separating the ventral from the dorsal. You're separating the basal from the alar plate. And if you can see it here, this is the basal, which is ventral, okay? And this is the alar, which is dorsal, okay? And what separates the two? The sulcus limitans. Again, this is anterior or ventral. This is posterior, okay? This is made up of a floor plate and the basal plate, and the posterior is made up of the roof plate and the alar plate. And what separates the back from the front, or separates the basal from the alar? The sulcus limitans, okay? Make sense, guys? So don't forget this. I know it's tough, but it's like you have to know it. Also, like let's go over what each one does. The floor plate creates the ventral midline of the neural tube adjacent to the notochord. Okay, so it's the ventral midline, and the basal creates the motor neurons and the preganglionic autonomic neuron. Motor and preganglionic autonomic. On the other hand, the roof or the creates the dorsal midline, so it makes the midline in the back, unlike the floor. The floor makes the midline but the front, and the alar plate makes the sensory neurons, okay, and provides the root of the spinal and cranial nerves, okay? So basal creates the motor neurons and preganglionic autonomic neurons. The alar makes the sensory neurons, which responds to input of the sensory root spinal and the cranial nerves, okay? So يلا, you guys have to memorize this. خلاص الحين I don't want you guys to do it wrong. Now let's go ahead, and I think now we're going to start the spinal cord. So a 67-year-old man comes to the physician. Oh, not spinal cord. Okay, we're going to do now, we're starting the third lecture, which is the components of the nervous system. So a 67-year-old man comes to the physician because of a 1-week history of numbness and burning sensation in his leg. He also reports that his stool has been drier and harder than usual. He has non-Hodgkin's lymphoma. 2 weeks ago, so he has Hodgkin's lymphoma, guys. 2 weeks ago, he's completed his last chemotherapy cycle with prednisolone, vincristine, rituximab. I'm going to skip the names. You guys can read them. His temperature is 37, pulse is 89, and blood pressure is 122/80. So his vitals are pretty normal. Examination showed decreased muscle strength in the distal muscles of the lower extremities. Ankle reflex is 1 bilaterally, knee reflex is 2 bilaterally, so that's very low for a reflex. Sensation to pain, vibration, position is decreased over the lower extremities. Serum glucose, creatinine, and electrolyte concentration are within the reference range. Which of the following is most likely the cause of the patient's symptoms? Before I want you guys to go into the diagnosis. What is the normal number for reflex, and how do we assess a reflex? What's the range for it, and what's the normal? 5. Okay, so the normal is 5. The like no reflex at all is 0. So having +1 is very close to 0. It's very hyporeflexia, basically. So the goal is to always have 5, and obviously not more than 5. So what does anyone else have? Yusuf says he thinks it's Guillain-Barré syndrome, so he thinks it's D. Does anyone have another answer before like we go ahead and see the answer? According to my knowledge, it's 0 to 5, not 2+. Isn't the normal for reflexes 2+? According to my knowledge, but I'm not, D, everyone thinks it's D. 1 second, I will double check with the normal score of the reflex. While I'm looking for the normal score of the reflex, which I think is 5, can you guys explain to me in the chat why you think it's Guillain-Barré syndrome? Okay, so sorry, you're completely right. The normal reflex is two plus two, okay, and then above that is going to be hyperreflexia, and lower than that will be hyporeflexia. And I think the thing I had in mind, which is five, which is like the muscle tone, I was discussing that, so I'm going to discuss this also later. The table is there. So again, guys, I'm just going to confirm the normal is plus two, which is the average. One is low, three is too much, and so on. So, okay, so everyone, still, there's no other answer than D. Okay, so it's actually not Guillain-Barré syndrome. If you really think of it, they didn't mention any problem with previous infection. They didn't mention autoimmune disease. They didn't really show us any type of autoimmune disease because Guillain-Barré is an antibodies, right? I think, يعني. So actually, the answer is adverse effects of a medication. Okay, and you probably guys forgot this, but I'll show you here. The answer is adverse. Why? Because he was going through chemotherapy. And one of the ways we do chemotherapy is by blocking the microtubules. And so if you go back to the question over here, they specifically mentioned that he is a non-Hodgkin's lymphoma and he has chemotherapy using vincristine. Okay. And over here in the lecture, we learned that vincristine is a chemotherapy medication used to treat different types of cancer. Okay, vincristine works by binding to the tubulin proteins and disrupting the microtubules assembly. This prevents spinal formation. And what is the microtubules function? It's to transmit information from the axon to the body, and from the body to the from the neuron body to the axon. So it's kind of like the highway of the neuron, and you transmit nutritional things, receptors, and so on. So microtube, and they also give very important structural support. The problem with having a chemotherapy like vincristine is that it's not selective. So it's not only blocking the formation of microtubules of cancer, it's blocking also our own microtubules. So then you lose the structure of the nerves, and then you have this side effect of losing sensation. The thing about this, the pro thing about this chemotherapy type is that it does not cross the blood-brain barrier. So you will not have symptoms of the brain, but you will have symptoms of the peripheral nervous system. And they always describe it as a glove and stalk pattern. As you can see in the picture over here, it's the glove and stalk pattern where you can see that it's like he's wearing socks and gloves because it goes to the peripheries and it affects the nerves in the peripheries because of this microtubule, it blocking the formation of microtubules. Does this make sense, guys? If we reread the question again, they were really more focusing on the chemotherapy about it, and they weren't giving any symptoms about spinal cord compression. Spinal cord compression, as we will see later, and Guillain-Barré would show different symptoms. Like spinal cord compression would show pain in the back. It would show burning sensation. It would show some difficulty or feeling saddle anesthesia and so on. So there must be some specificity that indicates if it's Guillain-Barré or spinal cord compression. The keywords aren't there for this question. Is it clear now why this is why the answer is the adverse effects of the medication? Okay, so again, the focus and the keyword here is the vincristine. Okay, so let's go ahead and go to the next. And again, vincristine does not cross the blood-brain barrier, so it causes peripheral neuropathy. An investigator is studying a neural regeneration for microscope visualization, and stain is applied. After staining, only the soma and dendrites are visual, not the axon. Presence of which of the following cellular elements best describe the staining pattern? Any other answers, guys? Should we go for E? Any other guesses? F and E. Anyone else, guys? Okay. So the answer, okay, F. Yeah. The answer is F. And it's because over here, I'm going to show it to you guys. This is slide, histology techniques. So we have Golgi method, we have Nissl method, and we have Wiggert's method. The Golgi method is for branching patterns of dendrites and axons. In the questions, they specifically mentioned that there is no axons involved. The Nissl method involves demonstrating the nucleus, the cell body, the granular endoplasmic reticulum, and ribosomes. Okay? So rough endoplasmic reticulum and ribosomes. The Nissl body stains usually illustrates the size and the number of the neurons. The Weigert's method stain is for myelinated axons, which we said were not mentioned in the question. They specifically said not axons. So the options is they're talking about Nissl method stain. And Nissl method stain shows the nucleus, the cell body, and the rough endoplasmic reticulum with their ribosomes. So the answer is rough endoplasmic reticulum. Or if the answer is showed as well, it's ribosomes. It's another correct answer. Cell bodies, again, another right answer. And as well as the nucleus. Is it clear, guys? Okay, good. I hope you guys are like benefiting. I know like I'm the type that takes a lot of time per question, but I really think it'll help you more if I explain the concept as a whole rather than explaining one question, because this question won't come to you in the exam. It's the slide itself that's going to come to you. Sorry, guys. Gonna mute. Okay, guys, it stopped. It's okay. Don't worry about it. I'm at university and this happens every like 10 minutes. So, yeah, don't worry. No need to pause the recording. I'm back. You can hear me, right? Yes, okay. An investigator is developing a drug that selectively inhibits retrograde axonal transport of rabies virus towards the central nervous system. To achieve this effect, this drug must target which of the following? Okay, see, any other answers? Perfect. It is dynein or dynein. So just like, again, I'm going to remind you guys that dynein is going to the cell body and kinesin is going to the axon. So they're specifically saying that they want the one that goes to the central nervous system, or it goes to inhibit retrograde. The word is retrograde. And retrograde is basically going to the cell body. Anterograde is going to the axon or the axonal end. So we want retrograde, we want to the cell body, which is kinin. If it asked inhibit anterograde, you have to do kinesin. Okay, so this picture is like descriptive of it. Again, dynein to cell body, kinesin is to axon terminal. Okay, a 46-year-old man comes to the physician because of a 2-month history of hoarseness and drooling. Initially, he had difficulty swallowing solid food, but now he has difficulty swallowing food like oatmeal as well. During this period, he has developed weakness in both arms, had an 8.2 kilogram weight loss. He appears ill. His vitals are all normal limits. Examination show the tongue atrophy, pool oral cold oral secretions. They're mild spasticity on all extremities. Deep tendon reflex is 3+ in all extremities. Sensation to pinprick, light touch, and vibration is intact. And esophageal gastroendoscopy shows no abnormalities. Which of the following is most likely the cause of each of the patient's symptoms? Okay. Let's take this step by step, okay? I don't want you guys to rush into an answer. This is the worst thing you can do in anatomy. So I'm gonna annotate and show you, I'm gonna highlight with you guys. Highlighter and color. So let's see. So we have history of hoarseness, difficulty swallowing solid food, and swallowing food in general. So you have dysphagia, okay? Weakness in both arms. Okay, you have weakness. You have tongue atrophy. Okay. You have mild spasticity. So you have a mix of weakness and you have weakness and like dysphagia and seems like lower motor neuron. And you have spasticity like upper motor neuron. So we're seeing both symptoms. Deep tendon reflexes are 3+. And as we just learned now, we said 2+ is normal, 3+ is high. So this is spastic paralysis, okay? Sensation of pinprick and light touch is intact. So dorsal column is, sensory is intact. We can see pinprick, light touch, vibration are all intact. So the sensory is intact. There's no abnormality in the GI system, basically. What do you think the answer is? Wait, let me see. C, C, D. Okay, so we have D and then we have C. Okay. So the answer is, why do you think the answer, what is D? Like, why do you think the answer is D? I want you guys to tell me. And what makes you think, for example, whoever said C, why do you think it's C? Tell me, prove to me your answer. Because this is, I want you guys to analyze the question. Because we said we have both spastic and flaccid. Perfect explanation. So you're completely correct. The answer is D. It is destruction of the upper and lower motor neuron. And this is for lateral sclerosis. So I'm gonna remove, I don't know how to, I'm sorry. I will clear all my drawings, okay? So we are talking about amyotrophic lateral sclerosis, or ALS, okay? So ALS is exactly showing some lower motor defects and upper motor defects. And if we really go into detail about it, you have upper motor damage is responsible for hyperreflexia and spasticity of the patient's extremities. On the other hand, the bulbar palsy, due to the lower motor neuron, has caused this patient to have dysphagia and tongue atrophy. So sensory function is unaffected in people with ALS. So they specifically mentioned over here, sensation of pinprick, light touch, and vibration are intact. So sensations are intact. So let's go over and revise what ALS is. And again, like I said this in the beginning, thank you. This is Marwa's table, and I'm referring to her table. So ALS is caused by the defect in superoxide dismutase 1. So it's genetic, it's in your genes, okay? Bulbar palsy is basically a problem in the nuclei of the brainstem. So it's a lower motor damage in terms of, like, do you remember dysphagia and tongue atrophy? They're all things that we learned in the brainstem. Yes. Okay. So do you now remember what bulbar palsy is? Like it's something related to things in the brainstem that I haven't revised yet, so I'm not gonna do a full explanation of, but just keep in mind it's there. Okay. So it's definitely cranial nerves, because the cranial nerves are what are responsible of dysphagia and dysarthria and so on. Okay, so superoxide dimutase 1, combined degradation of upper motor neurons of the corticobulbar and the corticospinal fibers, and then you have the lower motor neurons of the cranial nerves and the anterior gray horn. The cranial nerves are responsible for the dysphagia, dysarthria, and all of these things, and the upper motor neuron, for example, the corticospinal tract, which is causing the spastic paralysis, okay? Mixed motor disorder, and again, it's caused by superoxide dimutase deficiency, and it's treated by a riluzole, and it's a mixed motor disorder. There's no sensory loss. Again, no sensory loss. Lower motor defects are shown as dysphagia and tongue atrophy and fasciculations, tongue atrophy and fasciculations, and then you have upper motor neuron defect, which is spastic limb weakness and hyperreflexia. And as we can see, the amyotrophic sclerosis is shown here laterally and anteriorly, and no sensory effects. Is it all clear? Can we go to the next question? Any questions? Clear. Perfect. 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 Okay, a 78-year-old woman comes to a physician for a follow-up examination. 3 weeks ago, she was diagnosed with herpes zoster in the right T10 dermatome. The rash has since resolved, but now reports continuous burning and stabbing pain. Burning and stabbing pain in the affected area. During the neurological examination, the physical test of the patient's pain and temperature on the right lower abdomen. Which of the following labels part of the upper thoracic spinal cord is responsible for transmitting the sensory information? So what is the keyword here? The keyword here, guys, is pain and temperature sensation. So pain and temperature is which specific tract? Spinothalamic. Which one? Anterior or lateral? Lateral spinothalamic. Perfect. So in the lateral spinothalamic, where is it located, guys? Show me tell me which exactly where. It's C, exactly. So it's over here. So this is where the problem is. So the answer is C. Good job. So any questions about this? Again, we have lateral spinothalamic, anterior spinothalamic. Lateral spinothalamic is responsible for pain and temperature. Anterior spinothalamic is responsible for crutet and pressure. The question here was asking about burning sensation and pain, which is the lateral spinothalamic. Just a reminder, dorsal column is responsible for two-touch discrimination, vibration, and conscious proprioception. Spinocerebellar is for unconscious proprioception. Okay, and the dorsal column, again, just a reminder that the dorsal column has the gracilis and the cuneatus. The gracilis is responsible for the lower extremities, and the cuneatus is responsible of the upper extremities. So having an injury in different fasciculi indicate different locations of the dorsal column. Okay, injury. Okay. This is a reminder of the spinothalamic tract about the decussation and so on, so that you just remember it at once. So it is considered a sensory tract. So you're going all the way from the bottom to the top. So you're going from the body, from like wherever the receptor is, for example, on the skin. You're going from the skin all the way to the dorsal root ganglion, which is the first order neuron, is the dorsal root ganglion. The second order neuron is on the spinal cord, which is the substantia gelatinosa. And then the second order neuron, it decussates on the level of the spinal cord, and it goes up and it becomes contralateral. So any injury above the spinal cord is contralateral. On the spinal cord, it's ipsilateral, okay? So anything on the level of the spinal cord is ipsilateral, anything below the spinal cord is considered contralateral, okay? So this is the spinal thalamic, and then it goes in the it decussates on the level of the spinal cord. It goes up, it passes through the medulla, and then it decussates. There's the third order neuron on the ventral posteriolateral thing in the thalamus. I'm not sure which one exactly. I don't know why I got some balloons now, but yeah, the third order neuron is in the thalamus. Okay, and then go to the cortex. Any questions here? Any confusion? All good? So again, the level of the spinal cord is going to be ipsilateral, the lower is going to be contralateral. Okay. 1 hour after undergoing a surgical repair of a thoracic aortic aneurysm, a 70-year-old man experiences severe pain in the thoracolumbar junction and weakness and the numbness of both legs. He appears pale and anxious. His temperature is, and pulse and respiration and blood pressure, all normal, except blood pressure, 95/65, very low. 120/80. Okay, physical examination showed decreased sensation of pain, temperature below the level of the umbilicus. Muscle strength is 1 out of 5 in the lower extremities. This is, guys, what I meant from 5. I confused it with the reflex, and I was like, oh, the reflex is 1 till 5. Actually, the muscle strength is 1 till 5. 5 being the most normal, I think, and muscle 1 being very, very weak, atrophied. Or weak muscle in the lower extremities. Proprioception and vibration sense are normal of both extremities. Sensation and motor function in the upper extremities, chest and back are intact. Which of the following is most likely diagnosis? Okay, before, again, I want you guys to analyze with me. Let's, I want to highlight the important points. So it was saying there's decreased sensation of pain and temperature in the level of the umbilicus. So you have pain and temperature, that's the spinothalamic tract. The muscles as well, they're decreased. Proprioception and vibration sense are normal in the lower extremities. So the dorsal column, guys, is not involved. Right now, we're only talking about the anterior part. Right now, we're not talking about the back. Why? Because the dorsal column, which is responsible for vibration and proprioception, is good. Sensation and motor functions in the upper extremities and chest and back are intact. So above the lesion, there's no issue. We have no issue above the lesion. Which of the following is most likely diagnosis? Yeah, go ahead, guys. What do you think? Okay, B. Good job. Not sure if 211620 said C now or before. I'm not sure. It doesn't show me the type. B. Okay. So the answer is correct. It's B. So it's anterior cord syndrome. And the thing that they're testing in this question is the incomplete spinal shock syndrome. Okay. So the incomplete spinal shock syndromes are hemisection, central cord, and the concept is like there is a problem in the spinal cord, but it's not full. So what are they? They're hemisection, central syndrome canal, syringomyelinic canal, anterior spinal cord syndrome, tibiatic syndrome, and posterior column syndrome. And I'm going to revise each one with you guys because these are the incomplete spinal cord syndrome, and this is what they're testing in this question. They're testing specifically the anterior cord syndrome that we're also going to go in depth. So the anterior cord syndrome, you guys are completely right. So because it shows upper motor and neuron signs below the lesions and lower motor signs at the lesions, okay, because you're losing the actual gray matter on the lesion due to the anterior gray horn are being affected here. You guys can see the anterior gray horn being affected here. The upper motor neuron signs below for hyperreflexia, increased tone, spastic paralysis, and so on. You have, since the corticospinal tract is affected, which is in the anterior, you have loss of pain and temperature below the lesion. Why? Because you have a spinothalamic tract involved. Okay? Does this all make sense? And don't forget that this is bilateral. You guys can see that the anterior spinal artery, when it's occluded, it does not include half the spinal cord. No, it occludes bilaterally. Both sides, you're going to have loss of pain and temperature. Both sides, you're going to have spastic paralysis. As you can see over here, you're completely losing the anterior part bilaterally on both sides, right and left. So I don't want you guys to be thinking contralateral, ipsilateral. There's no contralateral, ipsilateral here. It's bilateral. The spinal cord on the back, which is the dorsal column, is spared. So vibration, proprioception is not a problem here. Now, what is the artery that is causing this issue? We're probably going to have a stroke in the spinal, we're going to have a spinal cord stroke, a spinal artery stroke, because the spinal artery supplies the anterior thank you so much. Okay, sorry guys about that, and thank you for letting me share. So let's go ahead and continue. So I was saying the anterior spinal cord syndrome happens because the spinal artery is what supplies it. And if you have a stroke and so on, you're losing the anterior 2/3 of the spinal cord. So these are the symptoms you're going to see. Below T8, you can also have a stroke of the intersegment. The intersegmental artery also comes from the aorta. And if you have ischemia of it, you would have this symptoms of the anterior spinal artery occlusion. Okay, so this is what we just had in this case scenario. Let's go ahead and explain the other incomplete spinal shock syndrome as a reminder for you guys quickly. Then we have the posterior column, which is completely opposite. We're going to lose, what are we going to lose, guys? Obviously, logically, we're going to lose loss of tooth discrimination, conscious perception, and vibration. And you will have the posterior gray horns, which will also be lost. And so what is the symptom that we will see at the segment? If the posterior gray horn cells are affected, all sensations will be lost at the spinal cord level. Why? Because you're losing the substantia gelatinosa, which is the second order neuron of spinothalamic tract. So substantia gelatinosa is affected, causing bilateral loss of pain and temperature. These are spared below the lesion. So you will only have loss of pain and temperature if the posterior gray horn cells are affected on the level. So you will have that band-like shape on your waist. For example, if you're losing it on the level of your waist, you have a band losing pain and temperature on your waist. But then below that spinal cord level, you will have complete all from that injury all the way down. You will have loss of two-touch discrimination, conscious perception, and vibration. But the pain and temperature would be spared. Okay, is it clear, guys? Okay. Hemisection. Hemisection is when half of the spinal cord is damaged. So you'd basically have symptoms, all the symptoms, you'd lose everything on half of the body, okay? Some of it contralaterally and some of them ipsilaterally. So you would have, at the level of the lesion, you would have loss of all sensations. Below the lesions, you're going to have loss of two-point discrimination, vibration, conscious perception ipsilaterally. Why? Because the decussation didn't happen yet. The decussation of the dorsal column happens in the medulla, so it's still ipsilateral. But you will have contralateral loss of spinothalamic tract, which is pain and temperature, because the decussation happens on the level of the spinal cord. أما الموtor, you will have flaccid paralysis at the level and spastic paralysis ipsilaterally below the level. Why is it ipsilateral? Because the decussation happens in the medulla. So we still didn't decussate. We're still in the spinal cord. Okay? Are these symptoms clear, guys? The hemisection? Okay. So again, I'm going to show it on the picture here. You have loss of pain and temperature senses contralaterally because it's decussated on the level of the spinal cord. And then you'll have spastic paralysis and loss of the dorsal column ipsilaterally. And on the level, you're going to have flaccid paralysis. Below the level, you're going to have spastic paralysis. Okay, then we have central cord syndrome. The highlight, and I highly recommend that you think of the keywords here, is that it's common in older children, and it's usually due to an injury of hyperextending the neck. So you're hyperextending the cervical region. So for example, imagine hitting your neck like it's so hyperextended, you'll have an injury, ischemia to the hyperextended area, and so you will have like a problem in the cervical area. So it usually happens in older patients, and you will have cervical hyperextension causing ischemic injury in the central part of the cord. So what are the symptoms? Look at the picture over here, okay? So when you have this loss, okay, you have all of this area spared. But what is here usually? So you will have motor weakness are more present in the upper limb than the lower limb. Why, guys? Why? Because we're in the center. And in the center, we have the cervical region. I don't know if you guys remember, but the motor starts cervical and then becomes thoracic and then lumbar and then sacral. So the sacral region, which is the lower part, is usually spared because you see here, the sacral is probably going to be outside this pink line. So the sacral is going to be spared. So you're not going to actually have any sacral, you will have sacral sparing since it's the most laterally located gray horn or fibers. The fibers are the most lateral in the sacral. The cervical is the most medial. So the cervical is going to be the most affected because it's the most medial and closest to the central canal. Okay? So you will see lateral corticospinal tracts are affected, the cervical fibers mainly affected. So you'll have bilateral loss of the pain, temperature of the upper limb because you're in the cervical region, and you'll have sacral sparing because they are laterally located. They're very far from the central canal. Usually there's an intact two-point discrimination, vibration, and conscious proprioception, which is the dorsal column, because the dorsal column being here, it's usually very far from the canal for it to be affected. Okay, so you will have over here a loss of sensation and voluntary movement, except in the sacral dermatomes and myotomes. So you're going to have this shape because the sacral region is spared. Okay, guys, any questions? No? Okay. Then you have tabetic syndrome or tabes dorsalis. And from the word tabes dorsalis, you can assume that it's going to affect the dorsal column and roots, but it's caused by tertiary syphilis. So a lot of it's going to be involved with being sexually active and so on, and not using protection and so on. So what comes with it is that you have sensory ataxia, you have Sherritt's joints, shooting pain, and Romberg sign is positive due to impairment of proprioception. I'm just gonna double check something because I searched Romberg sign. Oh, it's when you're not able to stand straight if your eyes are closed. You're not able to walk straight if your eyes are closed because conscious proprioception is not working. Okay, so you're gonna have impaired conscious proprioception. So that's what Romberg sign is. Absence of deep tendon reflexes due to the affected dorsal roots. And then you're going to have dorsal root isn't completely destroyed, which causes shooting pain. So the word shooting pain, sexually active, sensory ataxia, all of these are kind of signs for tabes dorsalis. But again, it's tertiary syphilis, so infection is involved. Okay. Then you have syringomyelotic syndrome. Syringomyelotic syndrome is dilation of the central canal, okay? And it's dilation due to CSF, over CSF. I want you guys to differentiate between central canal syndrome, which is ischemia. You're actually having ischemia and hyperextension injury. And over here, you're having too much CSF. So you have to differentiate the reasons, okay? So when you have hyper CSF, the central canal is too big. And when the central canal is too big, the lateral spinothalamic tracts are the ones that are affected the most. And again, still, cervical fibers are affected most because they are the most medial. And laterally, you're kind of going to have this, the things are saved from this disease. And it's associated a lot with Chiari-1 malformation or Kari-1 malformation. So it's associated with this disease. So the result would be loss of pain and temperature, specifically in the upper region, as we said, because the cervical fibers are the most affected, while the lower remain unaffected because the sacral, the lumbar are like kind of farther from the center. So they're very much less likely to get affected. So you're going to have this cape-like distribution because the upper limb is only affected. So you're going to have like kind of like the upper limb or this cervical fibers being affected, and then the sacral, lumbar, thoracic are being spared. Okay, is it clear, guys? Clear? Okay, let's go back to questions now that we revised everything. Don't worry, guys, we're kind of like almost done. I know, like, I put a lot of questions, but inshallah it will benefit you. A 65-year-old woman comes to the physician because of a 3-week history of sharp stabbing pain in her lower back. The pain radiates to the back of her right leg and worsens at night. She reports decreasing sensation around her buttocks and inner thighs. During the last several days, she had trouble urinating. 3 years ago, she was diagnosed with breast cancer and was treated with lumpectomy radiation. Her only medication is anastrozole. Her temperature is normal, pulse is normal, respiration is low. Respiration is 12 per minute, and blood pressure is 130/70. Neurological examination C, 4 out of 5 strength of the left lower extremity and 2 out of 5 strength in the right lower extremity. Knee and ankle reflex are 1 on the right. Resting and sphincter tone is normal, but squeezing tone is reduced. Which of the following is most likely the diagnosis? Okay, let's go step by step again. I'm gonna take a highlighter and I'm gonna highlight. So she has decreased sensation around the buttocks and inner thighs. Do you guys know which dermatome this is? What do you think the dermatome here involved is? The buttocks and inner thighs. Any guesses? Sacral. Exactly. Sacral is involved. So sacral is involved. So, and then she has like 4 out of 5 strength in her lower extremities and then 2 out of 5 strength. There's not really a consistency. Ankle reflex is +1, so it's kind of low. And the sphincter is normal, but it's also reduced. It's not that strong. So seeing the position and she has stabbing pain in the lower back, pain radiating to her leg, worsening at night. Seeing her symptoms, guys, do you have any guesses? Seeing that she has stabbing pain, seeing that she has loss of sensation in the buttocks and the inner thigh, seeing that there's 4 out of strength in the left lower, but 2 out of 5 in the right lower. So there's not like they're not equal. But reduced squeeze tone. What do you guys think? Do you have any guesses? Okay, I'll help you guys. It's okay that you don't know. It's actually quad equina syndrome. Why is it quad equina syndrome? Because you're pressuring the sacral region. Okay, so it's quad equina syndrome. You're having this saddle like situation. It compresses the quad equina. Do you guys remember what the quad equina is? It's the horse tail like projections of the nerves after the spinal cord ends. So when you put pressure in it, you cause compression of the quad equina due to a disc herniation or tumor. And they gave you a history that she has breast cancer. So there's a high likelihood that she has a recurrence of the cancer. So that's why it's either disc herniation or the tumor. And you would have radiating pain due to the nerves being compressed. So the lower limb would show pain because of the compression. You would have absent knee and ankle reflex and hyporeflexia because this is a lower motor neuron injury because you're compressing the nerve itself. You're not compressing anything of the upper motor neuron. You have loss of bladder and anal sphincter control, which I don't, she said she had trouble urinating as well. So she has trouble, loss of bladder and anal sphincter control because the nerves in the sacral region are what's responsible of that. And then you have saddle anesthesia, and saddle anesthesia is exactly this. This is exactly what saddle anesthesia looks, okay? So that's why she said that her sensation around the buttocks and inner thigh is being lost, which is saddle anesthesia. Okay? Let's go to the next. A 62-year-old was brought to physician because of a 6-month progressive weakness in her arm and leg. During this time, she had difficulty swallowing and holding her head up. So you have difficulty swallowing and holding your head up, which involves cranial nerves, swallowing and so on. And then muscle examination show pooling of oral secretions. Muscle strength and tone are decreased. So you have decreased muscle tone and strength of the upper extremities. Deeper tendon reflex are +1. Oh, sorry, 1 minute. Okay, guys, it stopped. Sorry about that again. So we said deep tendon reflexes are +1 in the right upper and lower extremities, 3+ in the left. So you have hyporeflexia, and then you have hyperreflexia, and then another hyperreflexia because it says 4+ in the left lower extremity. Sensation to light touch and pinprick and vibration are intact. So the sensation are not involved. Which of the following is most likely diagnosis? Good job. So basically, we did this before. We said it's an upper and lower motor neuron. Sensations are not involved. So it's ALS. Good job. Does everyone know why it's ALS? Because like this is something like we already discussed before. Can everyone confirm that like you remember this concept that I explained of ALS being upper, and it's a mixed motor neuron disorder where it's upper and lower. And you have hyporeflexia and hyperreflexia, and it's kind of like a mix of both, and sensation is always spared. Okay. Let's go to the next. A 38-year-old man comes to the physician for a follow-up examination. He has quadriparesis as a result of a burst fracture of the cervical spine that occurred after a fall from his roof 1 month ago. He has urinary and bowel incontinence. He appears malnourished. His temperature is normal. His pulse is normal. His pressure is 104/60. Examination shows spasticity of all extremities. Muscle strength is decreased in proximal and distal muscle group bilaterally. Deep tendon reflexes are +4. Plantar reflexes senses response bilaterally. Sensation to pinprick temperature is absent below the neck. Sensation of vibration, position, and fine touch is normal bilaterally. So you have like sparing of the dorsal column. Rectal tone is decreased. There is 1 centimeter area of arrhythmia over the sacrum. Which of the following is most likely caused by the patient's symptoms? So the only thing spared here, so the motor is not working, the spinothalamic is not working, but the dorsal is working. Damage of the anterior lateral spinal tract. Good job. Good job. So it is an anterior segment over here. Yeah. We're good. Yeah, let's continue. So, anterior spinal theory, you guys all, as we said, all understand the concept for this as well, right? We don't need to go over it again. Or do you want a second revision? Because I'm also down for that. But يعني if it's clear, no need to repeat. Just let me know. I don't mind repeating it. If you want a revision. It's clear. Can everyone respond? Clear? Hiba, not here. Okay. Um, A 65-year-old with osteoarthritis comes to the physician because of a severe lower back pain and pain in the left leg. In the left leg pain, she had chronic lower back pain that is usually well controlled by ibuprofen. And 3 hours ago, her pain got worse when she picked up her 3-year-old granddaughter. The pain radiates from her lower back over her left outer thigh and knee towards the top of her big toe. Physical examination show a diminished posterior tibial reflex on the left side. Muscle strength is 5 out of 5 in all extremities and there's no sensory defect. Steroid injection into which of the following anatomical location is most likely to relieve her pain? I thought this question was very interesting and I never thought of it. So I don't know, yes, good job. It is E. So it's intervertebral foramen. And I put this question because I was confused about it in the beginning and I thought I was smart. Because basically I thought, oh, probably she has a disc because she's 65 years old and her disc is probably protruding. So I said the intervertebral disc is relieving her symptoms because it's the problem. But actually, it is probably intervertebral disc causing the problem because it's protruding on her nerves. But the thing is, you're relieving the intervertebral foramen because it's where the nerves are coming out. So that's the anatomical area that you want to put the anesthesia in because that's what's causing the pain, the actual nerves, not the disc causing the pain. The disc is causing the nerves to be in pain. Okay, does that make sense? I just put this question because I thought it was interesting. I don't know if it's really gonna make a difference. Yes, okay. A 51-year-old woman comes to the physician because of progressively worsening lower back pain. The pain radiates down her legs with lateral side of the foot. She has no trauma, urinary incontinence, or fever. She's good. An MRI of the lumbar shows a disc degeneration and herniation compressing the S1 nerve root. Which of the following is most likely the finding of her physical examination? Let us try again. Let's try another answer. So this is very hard to remember. It's just because we had the exact table of the reflexes we have to know in spinal cord. So the answer is D because biceps for C5, C6, brachioradialis reflex is C5, C6, triceps is C6, C7, quadriceps reflex is L3, L4, ankle jerk or Achilles tendon reflex, I'm not sure how to pronounce it, is S1, S2, and they specifically mentioned that there's a compression at S1. So they're basically expecting you to know the reflex. There's no diminishment of anus and genitalia because probably genitalia is not involved. And remember we had, that was S2, I think, herniation, but yeah, the answer is weak. I'm pretty sure they were asking about the reflexes here. So yeah, it is E. We're right for that. And it's just something that we kind of have to memorize. So let's memorize it together since we have to. So biceps and brachioradialis is all on the top. So the top is always C5, C6 because the cervical region is here. So it's the top. And then the triceps is C6, C7 because also it's the cervical region. Quadriceps is L3, L4 because you're doing the knee. And then you have the ankle being the last one or the closest to the floor, which is S1, S2. Okay. A 45-year-old woman is brought to the emergency department by ambulance after a motor vehicle collision. He's not responsive to verbal command and unable to provide any history. His pulse is 108 minutes per minute, and regular physical examination show ecchymosis over his neck and back. Neurological examination indicate damage of the spinal cord at the levels shown in the illustration. The patient injury is most likely located at which of the following spinal cord levels? So this basically fully depends on your knowledge of how the spinal cord looks. Good job. So it is E. And the reason why it's E is because they expect us to know this thing over here and this picture, and you're exactly right because of the lateral horn. So basically what you have to know is the cervical, the thoracic, the lumbar, and sacral, this is how they look. The cervical has a lot of white matter because of all the ascending and descending tracts, and has a large anterior horn because it creates the cervical plexus. Okay, so that's why you have the large anterior horn. On the other hand, the thoracic has a lateral horn because, which you can see here, because of the sympathetic. The anterior gray horns are much smaller than over here because you don't have the cervical plexus, because it's not going to supply the limbs, it's not going to supply the upper limb and so on. It's not going to make a plexus. The lumbar segment, on the other hand, over here has white matter. Its white matter is reducing. It's more gray matter because the anterior gray horn is much more larger because they're going to supply the lower limbs. Okay, and then we have the sacral segment. The sacral segment is a lot of white matter, but much more gray matter, sorry, a lot of gray matter and much less white matter because you kind of have more of the cell bodies rather than the axons, because all the axons actually already separated in the cervical region, in the thoracic region, in the lumbar region. That's why over here in the question, you can compare the images, which you're completely right about. The correct ways to think about it is that there is the lateral horn here, but you can also see this butterfly shape that you could compare to the picture and say, oh, this is the thoracic. So that's why the answer is E. Is it clear, guys? All clear? Yes, okay. So I want you guys not to like completely guess it, and I want you guys to have like a full understanding as to why you chose T6. Sometimes we kind of get the answer accidentally. I want you guys to know like this is fully the reference of why these type of questions. Okay. A 17-year-old boy is brought to the emergency department after being stabbed with a knife during altercation. Physical examination show a 4-centimeter stab wound on the right lateral border of the T1 spinosus process. An MRI cord shows damage to the area of the right lateral corticospinal tract at the level of T1. So you have right lateral corticospinal, so this is the motor tract, at the level of T1. Further evaluation was most likely show which of the following. So corticospinal, guys, I want you guys to remind me, where does it decussate? First of all, what is its function, and where does it decussate? In the medulla. It decussates in the medulla. Okay. And what is its function? Motor function. So what should be the answer? If we know that we're in this level of the spinal cord, the injury at T1, we know is it contralateral or ipsilateral? Because it didn't decussate yet. Is it ipsilateral or contralateral? Ipsilateral, exactly. Hiba, do you understand why it's ipsilateral? Because it didn't decussate. It decussates in the medulla. Above the medulla, it's going to be. Exactly. So, and then the function is motor function. Okay? So the answer is absence of right-sided motor function. So it's ipsilateral, loss of motor function. So the answer is E. And this is kind of a reminder of what the function of the corticospinal tract is. So over here, we have the corticospinal, sorry, I think I put the corticospinal, I actually accidentally put the dorsal column here, so we're going to ignore this. A 23-year-old woman comes to the physician because of an 8-month history of weakness and intermittent burning pain in her neck, shoulder, and arms. She was involved in a motor vehicle collision one year ago. Examination of the upper extremity show absent reflexes, muscle weakness, and fasciculations bilaterally. Sensation of temperature, pain is absent. Vibration and proprioception is preserved. Pupils are equal and reactive to light. Which of the following is most likely the diagnosis? Okay, let's go ahead and analyze this picture together. So she has burning pain. That's something important to know. Absent reflexes, muscle weakness, fasciculations bilaterally. We're talking bilaterally, okay? Sensation of temperature and sensation are absent. Vibration and perception is preserved. So we know the dorsal column is good. Dorsal column is good. Pupil are equal in reactive slide. We don't have cranial nerves involved. Which of the following is most likely the diagnosis? So you have a lower motor neuron muscle weakness and fasciculations bilaterally, and you have loss of temperature and pain in هذا. So what do you think the diagnosis is? Don't forget the dorsal is involved. So if really like go ahead and like decrease everything, okay, we can remove. We know it's not Brown-Squibb syndrome because Brown-Squibb syndrome should involve the dorsal column because it's half of the spinal cord, right? Amyotrophic lateral sclerosis shouldn't involve the sensory. It shouldn't. So we wouldn't have loss of temperature and pain, right? Okay. Tabes dorsalis is involved with the dorsal column, right? Subacute combined degradation, we didn't learn it. So we don't know anything about it. Okay. Syringomyalgia, we said it's in the spinal canal, and usually the dorsal column is spared, and usually the cervical region are involved, like the cervical fibers are involved, like the upper extremities. Okay. And so let's see the answer. Exactly, it's B. If we had a multiple sclerosis, is not related at all. Cervical disc prolapse wouldn't be that because you would have symptoms like we said before. We said before when we said the sacral, and so on. So, and you wouldn't have temperature involved in the cervical disc prolapse as well. So syringomyelia. And this is example, cervical fibers would get affected first. They are most medial to lateral. And I think over here, they said upper extremities are involved. They didn't say lower. Lower are completely fine. So cervical are affected. You have loss of pain and temperature of the upper limb, and while the lower limb are not affected, and you have effect of the lateral spinothalamic, which is pain and temperature reduction. 21-year-old patient has a lesion of the upper trunk of the brachial plexus, Erb's palsy. We're on the last lecture, and don't worry, these are the last 3 questions. So we're done, خلاص, almost. But خلاص, we're on the last lecture. A 21-year-old has a lesion of the upper trunk brachial plexus. Which of the following is most likely the diagnosis? See, exactly. So arm tending to lean medially. I'll show you guys why. Because the upper trunk Erb's palsy, they specifically mentioned it's Erb's palsy. It's hyperextension of the neck, usually happens at birth of the neck, or for example, this type of fall. So the root of the upper trunk of the brachial plexus is involved, and that causes the waiter's hand, which causes prolonged forearm and semi-flexed hand with an adducted arm. So that's the medial look, and the adducted arm being near to the body. The lower trunk injury would be Klumpy's palsy, which is the opposite. It's when you take out the baby with the hand, for example. This is a grabbing support during falling from a height, or as a birth injury. This is a birth injury in the neck, and this is the birth injury in the arm. And it's usually a grabbing support during falling and causes claw hands and the paralysis of the 4 lumbar muscles. This is what a claw hand looks. And it occurs usually at rest. So you have to differentiate between a lower trunk injury and a upper lung trunk injury. A 29-year-old comes with a stab wound, cannot raise her arm above the horizon, and would have a winged scapula. Which structure of the brachial plexus was most likely injured? Exactly, it's the roots because the long thoracic nerve is what's responsible of the serratus anterior muscle, which gives the winged scapula effect if it's paralyzed. And the long thoracic nerves come from C5, C6, and C7. Okay, so it's considered a problem in the root in order for the long thoracic nerve not to work. And it can be caused by radical mastectomy and stab wound of the lateral chest. So winged scapula by the paralysis of the serratus anterior muscle by the long thoracic nerve injury. Okay, a 16-year-old boy fell in a motorcycle. His radial nerve was severely damaged because of a fracture of his missed shaft of the humerus. Which of the following conditions are most likely the result of this accident? Likely result from this accident. Exactly, loss of wrist extension. due to wrist drop. Why? Because radial nerve causes wrist drop due to paralysis of the extensor muscles and the dorsal compartment of the forearm. It can also cause the injury of the anatomical snuff box, so you'd have sensory loss of the dorsal 3.5 digits. So, and dorsal 3.5 digits, meaning this area, this pink area, okay, which is a coin-shaped area between the first and second metacarpal bones. And then you have, this is a midshaft injury or of the anatomical snuff box. Okay, a 30-year-old suffered a superior gluteal injury of a motorcycle crash of the right lower limb, was caught beneath the bike. He was stabilized by emergency department. Later, he examined and exhibited a waddling gait and a positive Trendelenburg sign. Which of the following is most likely the cause of his physical findings? So we have the main keyword is superior gluteal nerve. So the answer is, it's not difficulty standing, it's not difficulty sitting. It's not weakening flexing. So the answer is actually the left side of the pelvis drops and sags and attempts to stand. And I'm going to explain why. So basically, what you're talking about in terms of difficulty standing and sitting down is actually the inferior gluteal nerve. Exactly, the inferior, so not the superior. The superior one is responsible of the hip drop. I don't know if you remember this picture where you're dropping. And they specifically said that it's the right lower limb. So the right lower limb is what's also not working. So the left side of the pelvis falls down when you attempt to stand on your right, because your right side doesn't work. So if you put weight on it, it can't support you. So the left would drop. So this is the Trendelenburg sign, which is affected by the paralysis of the gluteus medius and the gluteus minimus. And the ability to abduct, you won't be able to abduct the thigh and pull the pelvis up. Okay, so this usually happens due to posterior hip dislocation and injury. Last question, guys. Last questions, bear with me, please. A 45-year-old is treated at the hospital after he fell from his bicycle. Radiographic examination reveal a fracture of both the tibia and fibula. One of the physical examination of the patient is foot drop, but normal eversion. Which of the following nerves is most likely involved? It's actually E, it's the deep fibular. Exactly. So the deep peroneal fibular nerve is causing the foot drop because of the muscles of the anterior dorsiflexion compartment of the leg are paralyzed. Skin deficit is present on the first web space, so over here. And I think they mentioned here specifically that, oh, they didn't mention that he had loss of, they didn't mention that there is loss of the skin deficit. But yeah, this is the deep peroneal nerve injury. So we're done with the questions, but I just want to go over the nerves quickly because honestly, the truth is about these questions, like specifically peripheral neuropathies lecture, which is the last lecture by Dr. Vlad, it's literally all the same. It literally will just tell you the nerve and you have to tell them the injury, or they'll tell you the injury and you have to tell them the nerve. So it's literally just straightforward. It's not like spinal cord, not like brainstem. It's straightforward. So haram you lose marks for it. So I want you guys to just visualize the pictures with me. Just try as much as possible to visualize it with me so that you can like get the grade of the easy thing, you know? So upper trunk injury, we have Erb's palsy, which is waiter's hand. Lower trunk injury, we said Klumpy's palsy, which is when you have to grab, or birth injury, and you get the claw hand, and it occurs during rest. Long thoracic injury, we said winged scapula, which is the serratus anterior muscle, okay? And usually it's radial mastectomy. Musculocutaneous nerve injury is causing it's causing weakness of supination, weakness of flexion, and lateral aspect of the forearm, sensory loss, lateral aspect of the forearm. Okay, so this, and then the axillary nerve is on the neck. This is the highlight. I don't know if you guys remember this from MSK, but surgical neck of the humerus is where the axillary nerve is, and without it, you have deltoid muscle paralysis. So you're not able to take your hands up, I think the first 45 degrees. And then you have radial nerve, which is considered in the middle. So It's in the mid-shaft of the humeral fracture. So over here you have the fracture of the head. Over here you have the fracture of the mid-shaft and anatomical snuff box as well, or the scaphoid bone of the anatomical snuff box. And you have the wrist drop if you have mid-shaft injury. And injury of the anatomical snuff box makes you have dorsal 3.5 digits paralysis. Okay? So till now, we're done with 3 nerves. Now, median nerve. Median nerve can happen in 2 ways. Either the supracondylar fracture of the humerus over here, and that will give you benediction hand or hand of Benedict. Supracondylar fracture causes inability to complete a fist, so you're not able to actually complete a fist due to the loss of the flexion of the lateral plea digits. On the other hand, if you have the injury of the median nerve on the carpal tunnel, it results from the lunate bone dislocation over here. Okay, you would have the ape's hand, where you're not actually able to oppose the thumb like this. You're not able to do this. Okay, so this is due to the paralysis of the opponent's pollicis muscle, and you will also have the loss of sensation of the lateral palmar aspect of the 3.5 digits. And how do you test it? If they hold a sheet of paper between the thumb and the finger due to opposition loss, so they won't be able to hold the paper like this. And then you have the ulnar nerve. The ulnar nerve is completely opposite to the median, because to test him, you don't test it with the thumb and the index. You test it with the index and like another hand like this, and the middle finger like this, and you hold the paper, because it actually for the third and fourth finger it does the muscle. So if you fracture from the medial epicondyle, okay, so differentiate, this is the supracondyle and this is the medial epicondyle. This is supracondyle, this is medial epicondyle. Or you can break it from the hook of the hamate bone in the hand actually, and it would compress the nerve by the Guyon's canal. For the medial epicondyle fracture, you will have flexion, weakness, and radial deviation of the wrist and claw due to paralysis of third and fourth lumbrical muscle. And in the hamate, you would have a claw hand, Guyon's canal syndrome, which is the weakness of the intrinsic muscles of the hand. Okay, and you also have median palmar aspect of the 1.5 digits. You would have loss of sensation. And again, this is the test due to of holding the paper with these 2 hands. And then now the lower limb, you have superior gluteal. We said the Tremberg sign. Inferior gluteal, we would have a problem with climbing stairs or standing up due to gluteus maximum paralysis. Then you have femoral nerve injury that would cause loss of knee extension. And you had the anterior and medial aspect of the leg and foot. You would have anterior thigh and medial leg and foot. You would have loss of it. And then you have obturator nerve, which would cause loss of hip adduction, so you're not able to put your hip inside, and skin of medial thigh. And then sciatic nerve would be flail foot, lack of dorsiflexion and plantar flexion. You'd have a flare foot. And then tibial nerve would be standing, you won't be able to stand on your nerve. Common peroneal injury is foot drop and inverted foot. Deep peroneal, as we said, foot drop. Superficial peroneal is inverted foot. Congrats, guys, we're done. I know you guys pulled through so much. Thank you so much for studying. You guys understand. At least I had some people to talk to the past 2 hours. I really appreciate it. And I really hope at least I helped you 1%. Please go ahead and like scan this QR code. It's for us to be better as PAL tutors. Please go ahead and like tell me what you think of my teaching and how I can be better and how I can use my time in a more efficient way. Criticize, say anything. I'm very happy to hear your feedback. This is basically just for us, for PAL tutors, to be better. So please go ahead and do that if you can. And thank you so much again. And I hope I helped. And if you have any questions, please don't hesitate. And if you don't have, if you like wanna ask me on private on WhatsApp, like literally go ahead. I love teaching. I'm only a PAL tutor because I aspire to be a lecturer one day. So please ask me as much as you want, and inshallah I'll be here to help. And good luck with prepping for your midterm, and good luck with everything in life. والله يوفقكم وييسر لكم أموركم يا رب. That's all. Thank you. You're mostly welcome, guys. Thank you. Bye-bye.